Good afternoon, everybody. Welcome to the post-lunch session of today's CME on Immunohematology and Transfusion Medicines. In the post-lunch, we have 3 sessions, one on thalassemia, one on obstetric hematology, and the last one will be updates on transfusion medicine. Let us start the first post-lunch session. The topic of this session is thalassemia, care, cure, and CRUB. I take this opportunity to introduce the moderator and panelists of this session. The moderator for this session is Dr. Shraddha Kulkarni. Dr. Shraddha Kulkarni is a consultant pediatrician practicing in Pune. She has a special interest with child diet and nutrition, and she has active participation in thalassemia awareness programs. She has an experience of over 20 years in this field. I call upon Dr. Shraddha Kulkarni, madam, to please be on the dais. The first speaker, panelist, Dr. Avinash Vaksundar. He is a consultant ENT surgeon. He is practicing at Vaksundar ENT Clinic, Moria Multispeciality Hospital, and Cochlea Pune for hearing and speech, JANAKALYAN Blood Bank. Sorry, I apologize for that. Thank you for correcting me. Presently, he is a Chief Managing Trustee of Moria Multispeciality Hospital, JANAKALYAN Blood Bank, and he has more than 40 years of experience in this field. He is a renowned cochlear implant surgeon. He has authored books like Yes, Every Deaf Child Will Speak. He is a winner of IMA's Community Social Work Award 2020, Dhanvantri Puraskar 2016, Seva Gaurav Puraskar 2018, and several other awards. I call upon Dr. Avinash Vachasundar sir to please be on the dais. Welcome, sir. The next panelist, Dr. Ravi Bhushan Ramesh Godbole. Dr. Ravi Godbole is a consultant pathologist of Dr. Godbole Laboratory, Pune since last 18 years. He is a consultant and section head hematopathology at Dinanath Mangeshkar Hospital, Pune. He is a consultant hematopathology at KM Hospital, Pune, and his areas of interest is flow cytometry of leukemias and lymphomas and pediatric hematology. I call upon Dr. Ravi Bhushan Godbole sir to please be on the dais. The last panelist for this session on thalassemia is Dr. Shweta Lunkad. She has done her DM hematology from All India Institute of Medical Sciences, New Delhi. And she is attached with Avinash Cancer Clinic, Jupiter Hospital, Pune. And she is a member of ISHBT. I call upon Dr. Shweta Lunkad, madam, to kindly grace the dais. I hand over the mic to Dr. Shraddha Kulkarni to moderate this session.
Good afternoon, everyone. On this auspicious day of Ashadi Ekadashi, with so much nice, delicious lunch being made, and 1 to 4 is such a nice Punekar sleep time. So it's really just a very tough and very big challenge given to me by Dr. Atul Kulkarni to moderate this session of such a rare topic of thalassemia, but it's not rare. You will come to know after the session that it's not really rare. So I'm here, Dr. Shraddha Kulkarni, to moderate this session. We have many eminent speakers today, as introduced right now, and a lot of eminent faculties and practitioners here, online and offline present. So with this, I start with the topic thalassemia. To begin with, we have a lot of other faculties joining online, so I just think of giving you some background of thalassemia before we start actual session. So let us move towards thalassemia. So as you all know, thalassemia is a blood disorder. It's a genetic disorder, and it is caused by abnormal hemoglobin, like quantitative reduction in beta globin chains. So basically the hemoglobin which is produced is abnormal in abnormal percentages, and beta globin chains are low in quantity, so that the hemoglobin is not useful to carry and the oxygen towards the tissues, and that's why the child becomes anemic. And there is also a process of hemolysis which starts. So this much we as a UG knowledge, we know all this. And with this, the child usually this disease is diagnosed at the age of 3 to 6 months, when the baby is very small. Like pediatrician usually this usually comes to know about the anemia in the child. The child looks pale, and there is easy fatigability. There are some signs which are present there. So with the jaundice, hepatosplenomegaly, abdominal distension. So these are the basic signs which indicate us to proceed towards the diagnosis of thalassemia. As we see the epidemiology, as I told you, that we feel that it's a rare disease, but it's not. You can see in the slide, there are a lot of reports which are showing lot of prevalence in thalassemia dependent, transfusion dependent thalassemia. Prevalence of thalassemia carriers is about 3 to 4%. That means 3 to 4% population is undetected, or it is detected, but it's not showing signs of thalassemia, but it has capacity to carry this disease to next generation. Every year, approximately 1 lakh children with thalassemia major are born world over, of which 10,000 are born in India. I think 10,000 is big number, and 10,000 are being added every year to this number. So it's estimated that around 65,000 to 67,000 beta thalassemia patients in our country, with around 10,000 cases being added every year. So looking at this, I don't think this is a rare disease. Only thing is we are missing out some cases which we are not finding out and investigating. We are just taking them as anemia patients, and that's why we need to get aware about this, and we need to screen them in time. So as I told you, this was the clinical presentation, which is seen in early infancy. Clinical presentation continues with hepatosplenomegaly and protruding abdomen. There is expansion of bone marrow spaces secondary to erythroid hyperplasia. All these features, of course, can be minimized if we diagnose this condition in time, and if we treat them in time, like in very early infancy, if we diagnose, the thalassemia phases and the peculiar signs are minimized. So now coming with all this introduction, we'll start with actual panel discussion. My first question would be to Dr. Ravi Bhushan Godbole. Like as I told, when we see these signs, we send the patient to the laboratory for investigations. We have to do basic investigations like hemogram, etc. So, sir, how do we diagnose this thalassemia basically in pediatric age group?
We go to the so as we have already seen that clinical features of thalassemia, Dr. Shraddha has briefed us already. So the usual age at presentation is around 3 to 6 months in a thalassemia major baby, and child usually has severe pallor and hepatosplenomegaly causing abdominal distension. So when such a patient comes to a pediatrician, usually the basic investigations are done, and the simplest test is a CBC or a hemogram. And usually hemogram has enough clues to diagnose thalassemia by morphology itself. So in a peripheral smear, in addition, the basic type of anemia is microcytic hypochromic anemia. So the child will have hemoglobin usually in the range of 6 to 8 gram%. It can be very severe also. The hemoglobin may go down as low as 3 to 4 grams also. But the RBC indices are usually microcytic hypochromic. So the MCV will be low, MCH will be low. And the peripheral smear examination shows severe anisopoikilocytosis. That is, there is severe or very prominent variation in the size and shape of the red cells. You can see many pencil cells, target cells, teardrop cells. And in addition, there are features of hemolytic anemia in the form of polychromatic cells and nucleated RBCs. These two features are common to any hemolytic anemia because it indicates increased RBC production in the bone marrow. So the peripheral blood shows lots of reticulocytes, which are seen as polychromatic cells, and lot of nucleated RBCs also. I will show you a micro photograph. So this is a peripheral blood smear of a thalassemia major baby. As you can see, the RBCs are very small in size and there are many target cells. I think you can appreciate. Many cells are having a central dark circle and a pale area, again followed by a dark rim of hemoglobin. In addition, you can see lots of RBCs with a nucleus inside them. So these are nucleated red cells, which are normally never present in the peripheral blood. And I think you can appreciate some RBCs with a bluish tinge. These are reticulocytes or the polychromatic cells. So this is a typical blood picture of a thalassemia major baby. And to confirm the diagnosis, we can do a hemoglobin electrophoresis. The conventional method was alkaline electrophoresis, but now the most widely used method is HPLC, that is high performance liquid chromatography. And in HB electrophoresis, or if you use HPLC technique, you will find that the fetal hemoglobin, which is normally less than 1% in an adult, and in babies who are about 3 to 6 months of age, the normal hemoglobin F is less than 10%. But in babies with thalassemia major, the hemoglobin F is very high, usually in the range of 80 to 90%. And in patients with thalassemia minor, the only abnormality is elevated hemoglobin A2, which is more than 4%.
Okay, so basically the hemogram, the peripheral smear done which shows nucleated RBCs, and the diagnosis to be confirmed by HB electrophoresis. And specific some indices, do you want to mention that those are low or high in this case in peripheral smear?
Yeah, RBC indices, the MCV is the most important parameter because it indicates the size of red blood cells. MCV is mean cell volume or mean corpuscular volume. The normal range for MCV is around 80 to 100 femtoliters. And in thalassemia major or minor, both, the MCV is usually low. In thalassemia minor, it is very low, usually in the range of 60 or 65. In thalassemia major also, the MCV ranges between 60 to 70 femtoliters. So that just indicates microcytosis, but by itself, MCV is not diagnostic because the more or very common cause of low MCV is iron deficiency. So more than MCV, the blood picture is very typical in thalassemia major.
Okay.
We'll come to the diagnosis of thalassemia minor in the next discussion.
Okay. So basically beta thalassemia major and minor are mainly diagnosed by HB electrophoresis. My question to Dr. Shweta Lunkad is, once we diagnose thalassemia child, how to take care of that child? In short, how to manage a thalassemic child?
So thalassemia manifests as a spectrum in the sense it can be minor, it can be intermediate, or it can be major. Minor, as ma'am has already said, are usually asymptomatic and they just pass on the disease to the next generation. Intermediate is somewhere in between minor to major, they can behave anyways. And the major is a real challenge. These kids will present in the age of almost 3 to 6 months of life. A little late presentation of 3 to 6 months is there because in the first 3 months, the HbF is there and it tides over the first 3 months. But thereafter, as the HbF concentration decreases, these kids will present with all the symptoms that ma'am has already manifested. So once the child is diagnosed, the biggest issue here is the low hemoglobin. So we transfuse the child. Transfusion is given on almost a monthly basis with the aim of keeping the child's hemoglobin of more than 9. There have been different transfusion regimens. Some say 9, some say 10, some say 11, but the most cost effective is 9. Do not let the hemoglobin fall less than 9. With recurrent transfusions will come iron overload because each bag of iron, blood will give almost 200 milligram of iron. So now once the child has received almost like 15, 20 transfusion, or the child has reached the age of 2 years, that is the time when we start checking the ferritin for this child. And once the ferritin is more than 1000 in a major or more than 750 in an intermediate, we start chelation therapy. Chelation can be in oral form or IV form or subcute form, but all can, because this is going to be a long-term therapy, all can guess here that people will prefer the oral forms of chelation. So the most commonly used is Deferasirox. This is not it. Beyond transfusion and chelation, we need to monitor the child. Can I go to the next? So monitoring the child will come with a lot of tests. These are the tests. These are the tests. So we have to check this child again and again for the features of iron overload, for the features of reproductive organ damage secondary to iron overload, for the features of liver damage secondary to iron overload, for the features of cardiac damage because of iron overload. So this would be MRI, ECO, ECG, USGs, the reproductive organ workup, and so on and so forth. Recurrent transfusions, hence they have to be doing the HIV, HBsAg, HCV almost on a yearly basis. And this is next. This is the list of investigations that this child is subjected to. Other than this transfusion, chelation, and monitoring, the other option that this child has, which is a definitive treatment option, is a bone marrow transplant.
Yeah, ma'am, we will come to it
Yes.
later. So just to summarize, as Shweta ma'am said, the major treatment is blood transfusion and the chelation to prevent or to treat the iron overload and to monitor the indices which are related to these two treatments. So as we are seeing, the hematologist, the pediatrician, all the doctors and hospitals are managing the medical part. But right now the scenario has changed so that government and also the NGOs are also into the action to manage the thalassemia in a proper way, to take the care of the child of thalassemia patients and parents. So coming to the social aspect of thalassemia, I would like to ask Dr. Avinash Vachasundar sir, would you please elaborate the term Divyang, because I have heard that thalassemia is now included as a Divyang case. So what really exactly it means, term Divyang?
Initially, only visually challenged, hearing challenged, intellectually or mentally challenged, and orthopedically challenged. These were the 4 main categories which were taken under disability. But later on, as the evolution in law and social conditions occurred, they included many conditions in disability. And latest act that was passed, I suppose, in 2019, RPD Act, Persons with PWD, Persons with Disability Act. In that, they have taken almost 21 conditions of disability, in which our context is they have included some hematological conditions also. In that, bleeding disorders they have taken, and also thalassemia is also hemophilia, thalassemia. These conditions are they have taken included into disability, and all the facilities they are given to all other disabilities are also given to these thalassemia persons. In the sense, suppose travel facility.
So a lot of concessions or some facilities which are given to other handicaps, the same facilities are now being provided to thalassemics. So this is by government of
India.
India. Okay, and what about Saksham Movement, sir? Is that?
Very good question. Saksham is a organization, NGO, public charitable trust, which is looks after all types of disabilities. All 21 I said, in that dyslexia, mental disorders, hearing challenged, all the disabilities are taken care by this Saksham organization, and that is all over country, from Kashmir to Kanyakumari, Kutch to Calcutta, everywhere in all provinces and all districts, this Saksham is working. Another peculiarity of the Saksham is whenever there is an organization of Divyanga or disability, it is mainly either with the all persons with that disability or parents of the disability. But here all the concerned persons, in the sense clinicians, ophthalmologists, ENT surgeons, psychiatrists, medical fraternity, then paramedical, in the sense audiologists, speech therapists, physiotherapists, then parents of the disabled persons, Divyangajans, and Divyangajan themselves, and organizations which are working in that. So it's a umbrella organization in which all type of persons are involved and all type of activities are going on. That's a Saksham's work, I can say.
Okay, so Saksham and such NGOs along with government are providing some facilities to these kids. Okay, coming back to Dr. Shweta ma'am, as you were telling, what is the definitive or curative treatment for this thalassemia and what is current scenario in Pune?
So the definitive treatment I've already mentioned is bone marrow transplant. Thalassemia minors and intermediates are usually not offered this treatment because they do not need it, because thalassemia minors do not require transfusions, and intermedia also require it once in a while when they are faced with challenges like growth spurts or pregnancy and so on. It is only the thalassemia majors who require the transfusion throughout their life. It is these people that are offered bone marrow transplant. The transplant that is usually offered to these kids is a match sibling bone marrow transplant. Matlab, they should have a complete match available. And the success rate of this is usually to the tune of 90% if the transplant is done as early as 4 to 5 years of life. But with increasing age, the success of the transplant can decrease to 60 to 70% if the child has crossed the age of 10 years. Beyond the age, other things like the chelation of the child, the build of the child, how nicely he has been transfused, all this also contributes to the outcome of the transplant. And these were some of the side effects that ma'am just mentioned about the transplants. So some of them can be delayed engraftment, graft failure, especially for an unrelated transplant.
So what is the care to be taken for bone marrow transplant patients, and what is the current scenario in Pune? Like what is the percentage or number of patients as you actually go for bone marrow transplant?
So as for the care, one thing is like once a child is diagnosed of thalassemia, he has to be prepared for transplant. As I said, the entire outcome of the transplants depends on the fact how nicely the child is transfused, chelated, and what is the age of transplant. So the care is that he has to maintain that hemoglobin beyond 9. He has to maintain the ferritin of 1000 or 1500, somewhere there. And for that, he has to be on intensive follow-up with his transfusion center and thalassemia center. And but as soon as the child is diagnosed of thalassemia, a search for the donor should be started so that the transplant, because if the child finds the donor also, let's say at the age of 1 year, these patients most of the time belong to a poor socioeconomic background, or even if they do not belong, they become so economically exhausted by the time they come for transplant that the funds are most of the time low. So then you have to apply to different NGOs to fund them for this transplant. So all these gathering of funds and all will take a while, may take almost a year planning of transplant. So the search should start early. As for the Pune scenario, we have almost like 6 thalassemia transfusion centers in Pune. Rudhir in Sanjeevan, Ruby in Lax, Bharti, Sassoon Hospital, and Aundh Hospital, the government-owned hospital. None of them are providing free of cost transplant as of today. But then we are in touch with a lot of NGOs, and through that we can gather a lot of funds for these children, where almost like 6, 7, 8 lakhs can be arranged, and the father and the parents might have to pay 2 to 3 lakhs for the same. Beyond that, government Coal India scheme is available in AIMS Pune, in AIMS Delhi, and in CMC Vellore, and in CMC Ludhiana. In these 3 centers, the kids get almost 10 lakh rupees for a transplant, and the transplant is almost entirely free in these 3 places in the country. In Pune, I would say almost, I cannot quote the exact percentage of kids transforming into transplant, but then there are a lot of kids going ahead with transplant, and we have wonderful results because, as I said, we are able to pick them up early and give the transplant in the right time.
Okay, ma'am. And what about some centers, as you mentioned in Pune, they are giving some free transfusion facilities and some bed facilities?
So Sassoon is working entirely free of cost. Bharti Vidyapit, I think, is free of cost. Rudhir is free of cost. Even blood is free everywhere. On the government hospital is also free of cost. Inlex is charging a basic amount of the bed charges or something like that. Some basic registration charges. That is it.
Okay, fine. Coming to the recent advances in thalassemia, ma'am, could you please tell about some non-pharmacological or pharmacological recent therapies?
So ma'am has made an extensive list of all the recent advances. Let's go one by one. So gene replacement and gene editing is one thing that is being tried and has been shown to have a very good effect, especially in thalassemia intermedia. Till date, whatever data has been produced, it is showing that it is increasing the hemoglobin by 1 to 2 gram% from the baseline. A thalassemic child is already having very low hemoglobin. So we are yet to reach the final place when it comes to gene therapy in thalassemia, but the trial is ongoing in CMC Vellore. And hopefully, as of today, the estimated cost of gene therapy is almost 1 CR.
Okay.
For a child. But once I think India manufactures it, वो अपना एक generic version बना देगा. The other things, the other mentions were erythropoietin stimulating agent. So as we should know that the basic problem here is not inability to produce hemoglobin. It is the bad quality of blood that is produced. So EPO had been tried, but with not much of an effect. JAK2 inhibitors, hydroxyurea, thalidomide, and luspatercept. So of this, hydroxyurea is the oldest one. We use it routinely with our thalassemia intermediates, and it helps to increase the hemoglobin by 1 to 2 gram% and makes them transfusion free. Luspatercept is the newer kid on the available, and again it also increases the hemoglobin by 1 to 2 gram%, and hence the best choice again for thalassemia intermedia. But it is, since it is new, it is very expensive. JAK2 inhibitors and thalidomide have been tried with almost 50 to 60% response rates, again increasing the hemoglobin by 1 to 2 gram. So you must understand all these pharmacological agents by themselves are not sufficient in a thalassemia major child, because they are increasing only by 1 to 2%, and hence this child will still continue to require transfusions, and hence the only curative option as of today for a thalassemic major child still remains bone marrow transplant.
Okay, thank you, ma'am. So this was in nutshell regarding the management or care of a thalassemic child in clinical aspect. So as we have come to know, there is definitive treatment is lies only with the blood transfusion, chelation, and the bone marrow transplant, and the general care of the patient, as ma'am mentioned. So prevention is the major key, I think, because these all treatments are very expensive. They are causing lot of financial, mental, and physical burden to the child, also to the child, and as well as the whole family. As a parent, it is very painful to see so many pricks to the child being given, so many times admissions being done. So let us understand how the genetics of this thalassemia works. I am not going into the details, but as you know, this is a genetic disorder which is caused by mutations, and it is transmitted to the next generations. So if the two partners are basically thalassemia minor, there is a possibility of the child being affected with thalassemia major. So that is around 25% of the possibility of the child being born as a thalassemia major. Also, there is 25% possibility of child being born as minor. So each pregnancy it is 25%. That means every time there is likelihood that the child may be born with thalassemia major. And once the child is born, there is no way back. We have to go through all this painful procedure of diagnosis and the treatment and the further options. So prevention should be emphasized. So how should we prevent this thalassemia? This can be done by population education, the frequently telling aware and getting more and more people aware about this disease. Also general practitioners, pediatricians, gynecologists, the doctors also should be fairly vigilant enough to diagnose this disease early, to suspect this disease, also early screening of this the children. Now we had thalassemia awareness program this year. So in that we also emphasized on adolescents and college education population to screen for this community, to screen for thalassemia minors, because we have to find out the minors. We have to catch these minors. We have to counsel them that the two minors coming together and giving birth to the child can be hazardous. So they have to be careful enough while deciding about the child, and further genetic counseling of those who test positive for minor, and the prenatal diagnosis. In this aspect, I would like to ask Dr. Ravi Godbole sir, in ANC, suppose the minors are married, then what investigation should be done in ANC period to diagnose this thalassemia? And if ANC patients are screened, what is the prevalence in your experience?
So the prevalence in ANC patients is same as prevalence in the general population. So it is usually 3 to 4%, but it varies in different ethnic groups or in different communities, even in India. So the rates of thalassemia minor prevalence can go as high as up to 20% also. And in addition to thalassemia, there are certain other abnormal hemoglobins, which are also prevalent in certain communities. Like hemoglobin E is very common in northeastern part of our country, and the prevalence of hemoglobin E can be as high as 50% in some communities. So these abnormal hemoglobins also contribute to burden of thalassemia. If the hemoglobin E trait person marries a thalassemia minor person, then the child, if it is born with two abnormal genes, it behaves clinically like a thalassemia. So we have to understand that to prevent the birth of a thalassemic baby is the most correct way to prevent this disease. Now for this, we have to screen all the ANC patients. First screening test would be a CBC, but the definitive screening test would be hemoglobin HPLC. So the screening tests which are done in ANC patients are usually hemoglobin, blood group, then HIV, HbS, Ag, HCV, and other things. But many obstetricians and gynecologists are still not pressing for this hemoglobin electrophoresis test, which I think is very essential, because the incidence of thalassemia is much more than many of these infective diseases like HIV, HbS, Ag, and HCV. So screening of all ANC cases with HPLC has to be done mandatory. And if we find that ANC mother is a beta thalassemia trait, then husband's HPLC has to be done to screen for a carrier status. And if by chance both the partners are found to be beta thalassemia minor, then molecular tests to screen for the common beta thalassemia mutations are undertaken to know the child's status, whether the child which is going to be born is going to be a thalassemia major or not. So these are further tests, but the basic test would be HPLC for all ANC patients.
Okay, sir, if both are minor and if they test for positive for both, then what is the further course in ANC?
Yes. So if by chance both the partners are found to be thalassemia carriers, then molecular tests have to be done. These are PCR-based tests to detect the genetic mutations in the parents as well as in the child which would be born. So what is usually done is both the partners are first tested for molecular defects in their genes for thalassemia mutations, and usually the same mutations are carried in the baby. So unless we know the parents' mutations, it is difficult to diagnose the mutations in a child. So once the parents' mutations are known, then we have to obtain fetal DNA to test for these mutations in the child. So the methods to obtain fetal DNA would be either chorionic villus sampling at the age of 11 to 14 weeks, or by amniocentesis if the pregnancy is slightly advanced at 15 to 17 weeks. So by either chorionic villus sampling or amniocentesis, we can obtain fetal DNA, and then this fetal DNA is screened for beta thalassemia mutations, which we already know are present in the parents. So if the fetal DNA shows the same mutations as they are in the parents, then we can diagnose whether the fetus would be thalassemia minor or thalassemia major. And if it is detected that the fetus is homozygous, that is both the genes of the fetus are affected or abnormal for beta thalassemia, then the medical termination of pregnancy is indicated. So to avoid reaching this stage, it is strongly recommended to include HB electrophoresis or HPLC in ANC profile in the first trimester, so that the further steps and MTP, as we all know, cannot be done beyond 20 weeks. So if these tests have to be preferably done in the first trimester, so that definitive action can be taken, even if the fetus is found to be thal major. And as we have already been stressing, that the best way to prevent this is to prevent the birth of a thalassemic baby by screening. And prevention will be always better than cure.
Okay, thank you, sir. So take home message for us and basically the gynecologist is please insist for HbA1c. Please include this HB electrophoresis test in first trimester of pregnancy to avoid these further hazards. My next question would be to Dr. Vachasundar, sir. Sir, would you please share the efforts which are taken by JANAKALYAN Blood Bank for thalassemia in general and thalassemia campaign?
Right since inception in 1983, JANAKALYAN has catered to thalassemia children by providing free blood units. When it was not compulsory by law, today it is compulsory by law that you have to give, every blood bank has to give free blood to the thalassemia patients. But when it was not that legally compulsory, since beginning, we are catering this, giving this blood free to the thalassemia patients. Advanced technology used to process this blood at our blood bank, Buffy coat method of separation, NAT testing for HIV and hepatitis B, C, storages, cross-matching, and mainly irradiation also. So all this advanced technology is used when we are going issuing blood to thalassemia patients. Around 200 such children are registered with us and currently, and minimum 2,500 units have been given free every year, and number is rising every year by 20%. We are, we can say that we are issuing major chunk. If you consider Pune's total issuing for thalassemia, I can say more than half at least we are issuing these thalassemia patients.
And what are the recreational or motivational programs? Are there any taken like counseling? And
yes, this is also, we are not only issuing blood or to these thalassemia patients, but as you have very rightly said, they are emotionally too much under stress, strain, when they know and when they are facing all these things, it is very difficult to face the situation. So regularly we are taking recreational and motivational programs for these parents. We conduct these programs and we call these parents with their kids, and counseling is done for these parents. Awareness sessions for thalassemia prevention is also done, and keeping up their moral is also very important function we feel, and that is also done very regularly. I think that is another aspect the JANAKALYAN Blood Bank is doing, not only issuing blood units, but they are our family, these society's members, and they also need to be kept in high moral. So all the possible things that could be done for them is done at our blood bank.
Okay, thank you, sir. Now coming to the end of the session, I would like to ask each of you, like, what should be the your point or view in achieving the goal of thalassemia-free Pune, because this would be the ideal situation rather than counting the numbers of thalassemic patients being added every year and counting the number of bags being dispatched. So this would be the ideal situation, like we should have one or the other day thalassemia-free Pune. So Dr. Shweta ma'am, what's your point of view as a hematologist to how can we reach this as a thalassemia-free Pune?
As of today, it is estimated that Pune has around 5,000 to 6,000 thalassemics.
Yes.
And we are adding every day. Only in Rudir, we are having every day new registrations. I don't know about the other 6 or the 5 thalassemia centers in Pune. So we're adding each day a considerable number of thalassemics to this count. This is a dream. A lot of countries have achieved it. The roadmap has already been drawn and explained by Dr. Godbole very nicely, where he said prevention is the key. It is all good on paper, but in practice, we are still lacking. So how we can go ahead is, one is thalassemia is more common in certain communities, the Sindhis and the Kolis and the other communities. So we need to reach those communities and we need to tell them about thalassemia and the problems of having a thalassemic kid, the problems of having daily, monthly blood transfusion, chelation, and the economic and the social problems of the same. Second thing is, we need to test all the kids when they enter the reproductive age group.
Okay.
Third thing, if we cannot do that, at least all the ANC expecting mothers, so that she has the information whether she is likely to have a thalassemic child or not. Second thing, she has the information whether this child is going to be a carrier or a major child. And accordingly, she can make an informed decision whether she wants to raise this child or not. You cannot tell a mother that this is going to be a thalassemic child, now abort it. You cannot do that. But at least we can give her that information and tell her that this is a choice that you have and you can go ahead with it if you want.
Yeah.
And this is the only way we can go ahead with a thalassemia-free Pune, thalassemia-free India.
Thank you. Dr. Godbole, sir, your view?
As we have seen earlier also, prevention would be the key, and prevention is possible only by screening for thalassemia. And CBC in itself is a very powerful tool for screening thalassemia, not only in ANC patients, but even in routine CBCs. Nowadays, there is a trend for these company health checkups, and lots of people are doing preventive health checkups. And CBC is always a part of these preventive health checkups. And one of the earlier slides, we had shown that to screen for thalassemia minor by CBC, there are very clear clues. When the hemoglobin is slightly on a lower side, maybe in the range of 10 to 12 grams, MCV is usually disproportionately low. It is in the range of 60 to 65. I mean, for hemoglobin of 11 grams, if it is because of iron deficiency, we expect MCV of around 70 or 75. As the hemoglobin goes down, the MCV also starts going down. But if the hemoglobin and MCV are disproportionate, I mean, hemoglobin is not very low, but the MCV is very low, And in addition, if the RBC count is very high, which I mean, if these three are mismatched, hemoglobin slightly low, MCV disproportionately very low, and RBC count disproportionately very high, this combination is quite typical of thalassemia minor. And even if you suspect thalassemia minor from a CBC report, we always advise to get it confirmed by HPLC. And one thalassemia minor diagnosed, once it is diagnosed, the entire family needs to be screened for thalassemia minor. This disease is undetected even at the age of 60s and 70s and 80s also, because this is a genetic disorder, and the patients are usually asymptomatic. So they remain undiagnosed to any age. I mean, unless it is screened, they never come to know that they are thalassemia minors. And once that trait is in their family, it is usually in any of their next generations. So this screening, not only for ANCs, but even in routine CBCs, I think it will help us to diagnose many thalassemics which are undetected.
Thank you, sir. This is very important for us because we are day to day seeing a lot of CBC reports. We should be vigilant enough to see this hemoglobin and relatively low MCV, as you said, and the high RBC count. Dr. Vachasundar, sir, your points.
What I would like to say that this could be a movement. Thalassemia-free Pune or India, this could be a movement. चळवळ, गांधीजींनी दांडी यात्राची चळवळ केली. ही चळवळ होणं अपेक्षित आहे असं मला वाटतं. फॉर दॅट डॉक्टर्स अँड सोशल वर्कर्स अँड अदर पीपल शुड कम टुगेदर अँड देर शुड बी व्हेरी रेग्युलर coming together and functioning of this. That is another thing that I feel. And thirdly, I personally feel that I'm an ENT surgeon. Nowadays, I see that whenever there are admissions of junior KG or under mini KG, at that time, the kids at some this type of preschooling, they have made compulsory of audiometry. They have made compulsory audiometry. So like that, when the admissions are taken, there should be compulsory testing, at least hemogram, simple test, that should be done.
This is actually good suggestion.
Yes, and if in that it will be immediately screened, and immediately at the age of 3 years, 2 years, one will know, and it's very simple. Now, audiometry testing cost, depending on the units where you are doing that, from 2,000 to 3,000, 5,000. This is a very simple test, one prick, and it has to be done. So, like this, why I said movement, by moving that, government is very thick-skinned. We all know. So, we have to make a lot of efforts to make this through government that before schooling or before college, they have to do this type of testing. That will solve many problems that way. Thank you.
Thank you so much, all the panelists. I just want to show you one video. This is by our Honorable President IMA. This is done in Thalassemia Awareness Campaign. Just go through this.
हॅलो नमस्कार, मी डॉक्टर मीनाक्षी देशपांडे, प्रेसिडेंट IMA पुणे. मी एक कन्सल्टंट गायनेकोलॉजिस्ट आणि स्त्रीरोग तज्ज्ञ पण आहे आणि त्यामुळे हे मेसेज किंवा हे सांगू इच्छिते की थॅलेसेमिया हा अत्यंत गंभीर आजार आहे. लहान लहान मुलांना रक्त भरायला लागतं आणि रक्त भरल्याशिवाय त्यांचं जीवन सुखकर होत नाही. त्यामुळे तुमच्या लग्न धरायच्या अगोदर जर तुम्ही थॅलेसेमिया कॅरियर आहात की नाही हे जर चेक करून घेतलं तर फार उपकार होतील समाजावरती. एवढं एवढंच सांगू इच्छिते की प्रत्येक नवरा नवरीनी आपापलं थॅलेसेमिया कॅरियर स्टेटस चेक करून घ्यावं आणि मगच लग्नाच्या घोड्यावर चढावं. धन्यवाद.
Thank you so much for the patient listening. Thank you.
Thank you all the panelists and moderator. Thank you for keeping all the delegates alert and awake in the post-lunch session. As a token of gratitude, I call upon our President Meenakshi Madam to felicitate the panelists and the moderator. I call upon our secretaries Alka Shirsagar Madam and Gitanjali Madam to come on the dais. President-elect Raju Varyani sir to come. Moderator Dr. Shraddha Kulkarni. Madam, please accept the token of gratitude. Samuri. Next, Dr. Avinash Vachasundar sir. Please accept the token of gratitude. Dr. Shweta Lunkad, madam. And last but not the least, Dr. Ravi Bhushan Godbole, sir. Please accept the token of gratitude from IMA Pune. Thank you, and I request everyone to wait for a group photo. Thank you, everyone. I hand over the mic to our secretary, Dr. Alka Shirsagar, madam.
Thank you, Virendra. Thank you, all the panelists. Now, the next panel discussion is on obstetric hematology from a clinician perspective, test and protocols in obstetrics. So for this, I call moderator Dr. Chinmay Umarji on the dais. And with him, the panelists, Dr. Tushar Patil sir, Dr. Harshad Parasnis, Dr. Vivek Joshi, and Dr. Aparna Sambus. Okay. Yes. Okay. Yes. सगळे कोविडनी डाऊन आहेत आणि एक मॅडम आहेत त्या बाहेरगावी गेल्या आहेत. सो येस मॅडम, डॉक्टर आरती निमकर मॅडम and Dr. Meenakshi Deshpande madam, you also join. Yeah. Yes. Yes. Harshad also down.
हो ना
Harshad.
सर काहीतरी इमर्जन्सी मध्ये बिझी आहे.
Okay. See, all the obstetricians and gynecologists, they are always busy. So, yeah. I'll do this. It's okay. Kaga, it's okay. It's okay. This. Hello, I will introduce now Dr. Chinmay Umarji. He is obstetrician and gynecologist, specialization fetal medicine expert, and his own having Umarji Mother and Child Care Hospital at Baner, and his experience in the field of 13 years. It's a very short introduction. Okay. The next slide, Dr. Tushar Patil sir. He's a pathologist and transfusion medicine specialist. He's working in Pimpri Chinchwad Municipal Corporations, a postgraduate institute, YCM Hospital, Pimpri, and years of experience is 22 years. And currently he's a professor and HOD pathology with additional charge as in charge of ICM Hospital Blood Center. And Dr. Meenakshi Deshpande, she is our president, and she's a gynecologist. And I think many things to be told about her. And Dr. Aarti Nimkar, madam, she's also a practicing obstetrician and gynecologist, and she's our past president. So with this short introduction, I will give hand over mic to Dr. Chinmay Umarji. I didn't know. I thought.
So true. So I'm immensely grateful to Meenakshi ma'am, Aarti ma'am for honoring us on the dais, and Alka ma'am for suggesting it. Never came to my mind. As she said, we are down. Half of our team is gone with COVID, and somebody had to leave for an emergency. But I'm sure we are going to make it quite interesting and clinically useful for you. Just for my understanding, how many of us are obstetricians in the group over here? And online, if I could know. Yes, I know. Yeah. And our online audience, if you want to just interject and raise your hand, if you're an obstetrician, I'm able to see over here in the chat box. Right. So today's agenda is to look at the entire course of her pregnancy and understand how hematology can help us during the course. So right from preconception, antenatal, obstetric hemorrhage, and postpartum. And although it is sort of sudden, we have the most talented panel over here, and I'm sure we are going to get to the answers quickly. So Meenakshi ma'am, if you want to just tell us more about anemia and pregnancy and how it poses challenges as an obstetrician.
Hello. Anemia actually, even now, yesterday also in the FCGP lectures which is going on, anemia is the most commonly found illness. You cannot say illness, it is a morbidity which you find in the mothers. And even if at the starting of the pregnancy, the hemoglobin is 11 in pre-pregnancy state, at the second, third month of pregnancy itself, the hemoglobin starts coming down. And even if the person or the girl or the woman feels tired, you just go and get a hemogram done rather than a hemoglobin, so that you will get to know all the cellular characteristics of the patients.
Very nice.
So better to do a hemogram. Then you will know the real idea whether the hemoglobin is correct or not.
Absolutely. And Tushar sir, if you want to tell us more about types of anemia you come across as a pathologist.
Yes, basically in as a government norms, basically in ANC package, my hospital, they are doing only hemoglobin, but they are not doing CBC. As madam has rightly pointed out, the CBC is very important investigation where you can get the idea about the hemoglobin, hematocrit, red cell distribution width, the RBC indices, MCV, MCH, and MCHC, which enlightens us on various things. By looking at those RBC indices, we can judge whether the anemia is nutritional anemia because of iron deficiency, B12 deficiency, and or the mixed type of pattern. Then red cell distribution width is giving the idea about the distribution of the red cells, and which is normal or it is increased. That can also give some clue. And the most important, once HB is low, my dictum is to make a smear and see under the microscope to find out the RBC morphology, what indices are reflecting and what actually I am seeing under the microscope.
Excellent.
Another thing is sometimes in thalassemia major, we get lots of nucleated RBCs. So that can give rise to very falsely high WBC count. So that will be looked after in the peripheral smear. So I will suggest the CBC and peripheral blood smear will be the most important thing as a screening investigations in all.
Great. Thank you so much, sir. Aarti ma'am, if you want to tell us about first visit in pregnancy. Now she's pregnant, she's 6-8 weeks, she has missed her periods, pregnancy test is positive, come to you. What are the hematological investigations you would like to order?
Yes, as Dr. Patil said that, like the total hemogram,
Yes.
then blood sugar,
Yes.
then thyroid test, at
Yes.
least TSH, and blood group.
Absolutely.
Blood.
Absolutely, sir.
It is important.
And would you also like to order hemoglobin electrophoresis at this stage?
If the hemoglobin is less and the, as she said, HCV
Yes.
and RBC
Yes.
percentage, the comparison is not matching. That time we do the ferritin and other hematome.
Great.
Right.
And that is the most cost-effective way of doing it. In the Western world, actually, that is done because hemoglobinopathy is not that much prevalent. We live in a country where 1 in 20 are hemoglobinopathy carriers.
Yeah.
So maybe should we change the protocol a bit and start advising HB electrophoresis to everyone, ma'am? What do you think?
No, not like that. Because only if the hemoglobin is below 10 and the MCV is very less
Right.
and RBC count is high, that time we advise.
Right.
Otherwise, the 9 and if it is iron deficiency anemia, we can treat it very nicely.
Absolutely.
Yeah.
Absolutely. Because now there is one more advantage of ordering HB electrophoresis. Tushar sir, if you want to tell us about that, and should
Yes.
that help?
So basically by looking at the CBC,
Yes.
if MCV is less than 75
Yes.
and MCH is also low and RBC count is not matching with the hemoglobin, what we call as a Menzer index, where we divide the MCV divided by the RBC count.
Okay.
And if Menzer index is less than 13, then usually we ask clinicians to go for hemoglobinopathy analysis.
Great.
Or they give the history that we are giving iron to the patient
Right.
and patient is not responding to the iron treatment.
Right.
So go for hemoglobinopathy.
Great.
So we usually ask the sample for hemoglobinopathy. We are usually doing this by HPLC method because the advantage is by HPLC method, we can screen the hemoglobinopathies as well as we get an additional idea about the HbA1c.
Yes.
As in India, diabetes is now becoming more and more prevalent. Almost 5 to 6% females are having diabetes.
Right.
So that's an additional advantage of HPLC. So by hemoglobinopathy, we can surely make out about the HbA2. When it is more than 4, it is indicative of beta thalassemia trait.
Yes.
If it is between 3.5 to 4, it is a borderline. So that time we take the help of the other investigations or serum iron, KIBC, and we try to correlate along with the retic count, LDH. We make a diagnosis about the thalassemia trait. Then we can get the other hemoglobinopathy like beta thalassemia major, hemoglobin E, hemoglobin C, and hemoglobin Punjab and other hemoglobinopathies.
Yes.
So we'll go for HPLC rather than a protein electrophoresis.
Great. Great. Thank you so much. So that really helps. And if I understand correctly, JANAKALYAN Blood Bank and Bharat Vikas Parishad who work with the grassroots. So your opinion on that? Are you kind of promoting anything else?
Considering current scenario and what we have discussed in our previous panel, though we have discussed two eminent pathologists and all these things, those indices and all these things, but still we feel that HPLC should be there for each ANC and they should get screened so that the cost of HPLC, and if you consider the outcome that you are going to diagnose a carrier, preventing the birth of thalassemics, then it makes a huge difference. So yes, from our side, we promote that each and every ANC, it should be screened by HPLC.
Thank you so much, sir. And
It may not be all ANC, but at least the first ANC
oh, very
has to
important.
go for HPLC,
That's excellent because yeah,
At
it will
least
save-
first.
Yeah.
compulsory.
Yes, absolutely, absolutely.
I
It'll
would
be
like
quite-
to add one thing is,
Yes, ma'am.
when especially the first ANC means the first visit of the pregnant patient should be between about 6 to 8 weeks.
Yes.
So we can, if she's anemic, severely anemic at that time, you will do a hemogram, then a serum ferritin, along with that a hemoglobin electrophoresis. Because if you add hemoglobin electrophoresis at that time only, you will come to know whether she is a thalassemia carrier. If you come to know if she is a thalassemia carrier, you can advise the husband's thalassemia carrier straight. And that is the right time when you can advise an MTP. Because if she comes at 15, 16, 17 weeks, again the time is lost.
So true.
So first visit itself, if you find patient anemic, very anemic, severely anemic, the first step of investigation is ferritin level and hemoglobin electrophoresis.
Absolutely. And just before coming to this esteemed dais, I analyzed our data from last 6 months. And out of 400 tests which we had performed, HB electrophoresis on pregnant mothers, 10 people actually tested positive, of whom 3 were partners. So 3 couples were HB electrophoresis thalassemia carriers, and we could potentially offer testing to them and potentially prevent thalassemia major and Dr. Lisa's work. So as everybody here very rightly said, beta thalassemia is an important challenge. So is the diabetes. And if like it's not that common in India, because many times we succumb, and pregnant patients, I mean thalassemic patients reaching up to a pregnancy, embarking on pregnancy, is that very rare. But we do come across a few cases now and again. So, ma'am, if you want to tell us more about how to correct anemia in these patients and how to manage them during pregnancy and labor.
In the first trimester, if anemia is severe, we can give the iron supplements. If it is iron, we have to see first the iron deficiency anemia, confirm that, and then give the iron supplements. In the food also, and as a medicine also, you can give the oral, or the hemoglobin is very low, you can think of the injectables.
True, true. And because injectables here are not iron, IV iron, it is going to be hepatotoxic to her. And some that is the reason why, as Madam rightly said, we want to give erythropoietin, and that too with the assistance of clinical hematologist. So maybe Melanie Carissa, if he's around, he can help us out. Ma'am is here, so ma'am can help us out. Ma'am, do you want to tell us more about how you would like to correct their anemia? Yeah.
Because erythropoietin, yes, we can use, but then we usually rely on the blood transfusion support mostly, and we try to maintain the hemoglobin around 8 to 9, because as I said, erythropoietin may or may not really help.
True.
Because erythropoietin will just increase the ineffective erythropoiesis. But then that is something where we don't really have much an option here. So we do use it sometimes, but the main focus is on maintaining the hemoglobin more than 9 with blood transfusions.
Great. And for a
At-
more
At what stage? When the hemoglobin is very
In a-
low? means at
In a thalassemia,
thalas-
throughout the
thalassemia,
pregnancy.
Yeah. But anemia is, if it is 8, 9, we can treat it medically.
In a thalassemic major, throughout the pregnancy, we try to
Thalassemia,
maintain
yeah.
it more than 9. In an intermediate, hydroxyurea, we are not very comfortable using in pregnancy. There are case reports where they have used hydroxyurea, but then it is not approved in pregnancy as of yet. So here also, as I said, intermediates are those who present only during the pregnancy because of the hematological challenge to the body. And in those also, we would support them with blood transfusion only. Again, here the cutoff is around 8 to 9 because we want the fetal well-being as well. We want the fetus also to grow.
Yes.
The patient is thalassemia.
If the patient, we are talking about thalassemia only. right?
Yes.
Yeah.
Now, a more commoner scenario where we have, say, a low hemoglobin mother, and we want to treat her. Please come now. Treat her with IV iron. Any tips? So she did not have HB electrophoresis done. her hemoglobin is say 9. How should we approach her?
Can I listen to the question?
Yes. So we have antenatal mother who had done a booking level hemoglobin, did not get HB electrophoresis, and her hemoglobin was 9. How should I treat this anemia?
So I would want to, I have time to investigate, right?
Absolutely.
So I would want to investigate her, as we have already discussed so many times, the importance of peripheral smear and the indices. And most probably in India, most of the time, almost in 50% of the cases, this comes out to be iron deficiency anemia,
Yes.
as ma'am has already pointed out. So in that case, we would start with just oral iron replacement.
Mhm.
And sometimes IV iron, depending how close to pregnancy how close to delivery we are. So if we do not really have much of a time, yes, in that case, I would prefer IV iron. Or if the patient is not tolerating the oral iron, I would prefer IV iron. Otherwise, oral iron is good enough.
Role of deworming?
Deworming, yes, we do deworming routinely. But then there's no but here. You can.
Right. Yeah, and
Usually we
current
do
government of India
deworming,
guideline
yeah.
also agrees with Dr. Lisa.
Deworming we do normally
yeah,
also
yeah.
at second or third, say in the second trimester of pregnancy.
Yeah.
Many times if the anemia recurs, I mean, even after correcting a hemoglobin, again the hemoglobin falls after 1 or 2 weeks.
True.
Then we do a deworming along with the hemoglobin repeat
Yeah.
status.
1 tablet of albendazole 400 milligrams. The current government of India recommendation it is. So absolutely right. Now this patient was refractory to oral treatment. Would you like to do HB electrophoresis before you give IV iron, or?
Honestly, any pregnant women entering in my OPD, I do HB electrophoresis.
I think that's the take-home message.
So I do it because we have discussed all the scenarios of MCV, MC, HC and all that. But there is something known as silent carriers also. So
True.
silent carriers are those who do not have, who have a normal hemogram and still can be health carriers. And hence every pregnant woman entering HPLC is ordered unless it has been done in the previous pregnancy, as has already been mentioned, because HPLC is not going to change with every pregnancy.
Absolutely.
So yes, that I am assuming was done.
Yes. And absolutely. So this is actually the Western protocol wherein they say microcytic normochromic anemia, treat them with iron. And if they are not responding, then go for testing unless there is ethnicity. So of course, Indian subcontinent is included in that ethnicity. So every person from Indian subcontinent ideally should get HB electrophoresis. I think Vachasundar sir said before they even embark on a marriage. So ideally in their college days. Moving on. So now we have made an antenatal screening in mother. Sorry for this. I'll just go back. Yeah. We have made a screening, and now we know that the mother is HB electrophoresis. She has increased fetal hemoglobin, so she is thalassemia carrier. How would you like to approach, ma'am, in this case, Meenakshi ma'am? Mother is thalassemia carrier.
Yeah, but how many weeks it has been?
She's 12 weeks.
If she's 12 weeks, then we have to go in for her husband's
Absolutely.
thalassemia carrier status. Because unless we know about the carrier status of the husband, you cannot detect whether a 25% chance is there of a thalassemia.
So
if
true.
both the husband and the wife are 20 at thalassemia carrier status, then the chance of the fetus having major thalassemia major is 25%.
Absolutely. Absolutely. And then if both of them are carrier, we would like to counsel them that potentially pre-delivery diagnosis is possible through a procedure which is on your screen right now called chorionic villus sampling. So you look at the babies or baby, depending on their placentation, if they are not sharing the placenta. So this is a single baby. Let me see. So that's my needle going into the placenta. And I'm sampling the placenta there. So CVS can give us a report like this. So here was a patient, previous child affected with thalassemia major, monthly blood transfusions, 2 transfusion reactions so far, And then when we looked at parental genotype, we realized that both the parents were beta thal carrier. The mutations were documented, and then we tested the fetus the next time. Fetus came out to be thalassemia negative. That is 25% chance. So we were super happy. 50% of them would be thalassemia carriers themselves. And at this stage, is there anything else we can do, doctor, to kind of help the first baby? If my fetus is fine, first baby is
So we
affected.
can save the cord.
Great.
So if we do the cord blood storage,
Yes.
we can use that in the stem cell transplant of the child who has already been affected.
Absolutely. So you can actually offer the cell typing and match the HLA of the fetus with the existing child on the CVS sample. If the HLA is matching, then this is a potential donor. And you don't need to bleed the donor at all. You can just give the cord blood, right? So you can potentially do that. Any novel therapies you want to mention at this stage? Suppose my baby was thalassemia major. Can I treat that now? Alpha thalassemia.
Hydroxy.
No, actually now, and this is very, very new. I don't know if I've put the slide there. Now, intrauterine gene therapy has been shown to be effective. There have been 3-4 cases in the Europe, other 3 cases in Asia, rather Japan. And what they have done is they have changed the genetic structure of the fetus and cured fetuses of alpha thalassemia. Beta thalassemia has not received approval from the regulators yet, but at some point of time. And similarly, Pompe's disease and many other genetic diseases now are rapidly getting approval for intrauterine gene therapy. So that will be probably the future. Now, let us move on to another common problem. So she was in her 12th pregnancy, previous 11 deliveries, only 1 living issue, lost 10 kids. Rhesus negative, referred with height drops at 22 weeks. So if you look at this fetus, this is fetal chest wall, sorry for the poor video. And you can see a lot of ascites there in the tummy. So there was height drops. Tushar sir, if you want to tell us, I'm going to presume that previous losses were all okay, and ideally I should be investigating this. She came from periphery of Mandavganj, so Baramati, and she did not have any investigations done on first 10 pregnancy losses. But we presume that probably they were okay, non-consanguineous marriage, first child 16 years old, she was doing well. Now, how would you like to take her from here? Say my first diagnosis, I mean, suspicion is RH isoimmunization. How should I investigate this case?
We should go for ICT, that is indirect Coombs test.
Yes.
Which has to be ideally, with this history, we should go on the first visit only.
Yes, sir.
Patient should have put the ICT. If ICT is positive,
yeah, then
there are basically 3 main reasons for ICT positive. One is either anti-KL antibody or anti-RH antibodies or anti-small c antibodies.
Great.
There are 3 things which are giving positive ICT. So basically, once ICT is positive, we should confirm that it is really positive.
Yes, sir.
It is not false positive.
Yes, sir.
Once it is positive, we can either go for the repeat testing after 1 month, or we can go for 11 cell panel testing.
Yes.
By that 11 cell panel testing, we can find out that what antigen is absent.
Wow.
And why she has developed the antibodies against the minor blood group antigens.
Yes, sir.
And if it is RH related, then we should send sample to the blood bank to confirm that the blood group is Pakka RH negative.
Yes, sir.
That is whether it is weak D or partial D or it is RH negative only.
Yes.
Because in the lab, basically most of the labs, they are doing blood group by the slide method, where we can easily miss the weak variants of RH. But this is a clear-cut case of multiple abortion. That means he has to be RH negative. But it's just a suggestion.
She was.
That
Yes, sir.
blood group has to be confirmed with the blood bank that it is RH negative.
Yes, sir. So, and while we're talking about confirmation of blood group, there are various methods, isn't it? And very confusing. So as a clinician, what should I know?
So basically, once it is an RH negative, the protocol says you should have at least confirmation of RH grouping by two different anti-D
Oh,
of two different manufacturers or two different principles. Basically, the RH, that is anti-D, what we use, it is a monoclonal and polyclonal.
oh.
So there are monoclonal IgM type, monoclonal IgG type, and there are blend antiseras where we get mixture of IgM and IgG. So in the blood bank, basically we are doing the RH typing by two different principles or two different entities.
Yes, sir.
Or we can use the other platform like gel technology
Oh,
or solid phase technology by automated instruments. And we confirm the RH group by multiple techniques. And we sure that this is RH negative.
so maybe when we are ordering our test for blood grouping or say cross match, should we insist on the lab that use gel technology or something like that? Or
Yeah.
I will not say that you should refer the technology per se, because still the age-old tube technique has its own merit. But definitely, if there is a RH negative case, then RH confirmation need to be emphasized, and that needs to be looked into. So just usually nowadays, I think pathologists also write as a footnote, if the group is RH negative, they will advise that they should get confirmed. RH confirmation needs to be done. So I think that is the crux. And what sir has rightly pointed, to confirm it, you should use two anti-Ds. So that, but that is again a part of ours, pathologist and all these things should look into it, that to confirm it, they should use two anti-Ds and RH confirmation if there is a they are suspecting RH negative.
yes, ma'am, if you want to.
How to cross match the this RH negative in the, if you baby needs the transfusion, intrauterine
Oh,
transfusion?
we are coming to that in a minute now. Tushar sir is going to talk about it. Just addendum to it, when we are trying to cross match, when we are talking about ICT and false positives, so sometimes false positives are very high on ICT.
Yes.
What could be the reasons and how to prevent that?
Basically, ICT positive means basically we are using the Coombs antisera or the Coombs test. So that is basically anti-complement as well as anti-IgG.
Yes.
So we should find out whether it is truly because of the IgG coating on the red cells in direct Coombs test.
Right.
And in direct Coombs test, we are taking the serum sample.
Yes.
We are incubated with O positive cells.
Hmm.
And then we do the Coombs antisera and we find out.
Yes, sir.
Because there in indirect Coombs test, the antibodies are present in the serum.
Yes, sir.
And in direct Coombs test, we can pick up the cells which are sensitized.
Yes, sir.
And they are having coating of IgG.
Yeah.
So the positivity can be because of the complement. It can be because of IgG. It can be because of the IgM.
Yes.
That is in saline reacting antibodies.
Yes, sir.
And there are the antibodies because of the minor blood group exposures. If by mistake patient has received some blood transfusion, she is exposed with some antigens,
Yes.
which are absent in her body. So she will produce the antibodies. So whether those antibodies are because of that nature. My morning session, Dr. Samir sir has already discussed about those other causes of the IgG antibodies.
Absolutely.
Because they are all acquired antibodies are IgG in nature, and naturally antibodies which are IgM in nature.
Yes.
All post-transfusion antibodies are usually IgG
IgG.
in nature.
Okay. So, and then I'm going to use this platform to kind of get an answer to a common query of mine. So she was anti-D positive, anti-KL positive, and now I wanted titers on her. When I was in Ireland, we used to get titers in international units per liter. Here we get dilutions. So what's the difference and how we can convert those? I mean, is it possible to get international units per liter here?
So actually here we are giving the serial Dublin dilutions, and we just give whether dilution is significant, where clinician should act or not.
Yes, sir.
So if the titer goes more than 1 in 32, then we say patient requires anti-D injections. But usually we don't practice of giving the in international units.
Yes, sir.
So usually
Yes,
we
sir.
give, but my suggestions will be if clinicians tell us that previously the ICT was positive, titer is so and so. Now I am sending the sample repeat. Then ideally I should repeat the test with the previous sample and
Absolutely.
new sample simultaneously, the same test, and we should tell them whether the antibodies are decreasing or antibodies are increasing in
Right. So I think that is very, very important, because as a clinician sitting in the OPD, sometimes I get confused. Last time 1 in 32 tha, is bar 1 in 16 hai. How should I interpret that? And I think the paired serum method, as sir rightly said, that saving serum from the previous sample, testing the new reagent with both the samples, and then issuing the newer report would probably allay that confusion. So thank you so much, sir, for clearing that up. Now, so we had anti-T as well as anti-KL isoimmunization query. We did not know baby's blood group yet. As you know, there was raised MCAPI and hydrops. Had that not been the case, I would not want to see the patient unless the titer crossed 1 in 32. Till that time, I would like primary gynecologist to look after the patient, do the anti-D levels every monthly. Afterwards, when it gets crossed, or every 15 days, if there has been such a bad obstetric history, because they are going to rapidly have increase in the titers. And once the titer crosses or a monthly scan shows a raised in MCAPI, then I would like to start seeing the patient more regularly. Now, my diagnosis here is, of course, isoimmunization, because everything else was potentially ruled out. How should I treat this patient, Arti? She's fetal anemia with RH isoimmunization.
Fetal anemia, isoimmunization.
Yes.
Yeah.
Intra and transfusion.
Hydrops, with
Yes,
the
ma'am.
hydrops.
Exactly,
Yeah.
exactly.
So intra-amniotic blood transfusion
Yes.
is the treatment now.
Absolutely, absolutely.
save
And
the baby.
to answer ma'am's question, sir, how should we prepare the blood? What should I ask for?
when you are asking the intrauterine transfusions, then preferably we give O negative. So once we get the order of intrauterine transfusions, we usually call the O negative blood donors,
Mhm.
and we try to prepare the leukodepleted blood, then preferably irradiated.
Absolutely.
So those things we.
Yes, and we want it to be tightly hemoconcentrated,
Hemoconcentrated.
because my fetus will not have that much of volume space. So I don't want to overload my fetus with the volume who is already in hyperdynamic circulation. So instead of a normal MCV, I would maybe
So we
want.
prefer the hematocrit of 70 and above.
Yes,
So that is
absolutely.
the best. For the
Absolutely, sir. And as sir very rightly said, and I'm so proud that JANAKALYAN provides it every time, fresh blood. When people cannot get rhesus negative blood, we can get a fresh blood, thanks to Dr. Tanvi and Dr. Sir. So that's very, very useful. And then moving on, this is how the OT setup looks like. So we need ultrasound machine, good quality ultrasound machine in the OT. We paint and drape the patient. Patient is not under anesthesia. She does not even need local anesthesia. She's nice and awake looking at her baby. And this is how the procedure is performed. So that's my needle on the right upper corner of the screen. Can you see? I've gone into the fetus. I've paralyzed the fetus, by the way. So we paralyze the fetus by an intramuscular injection of weak uranium. And then we go inside the liver. This is called intrahepatic transfusion. For a posterior placenta, intrahepatic transfusion is much easier. So we go like this. That's the needle. I'm looking at the umbilical vein going into the crescent. I go at the crux of the crescent. I sample the blood. Baby was also rhesus negative on the blood group. So why would that be? Because this was anti-KL antibody, not anti-rhesus antibody. And that is why she did not require as many blood transfusions. Anti-rhesus would have required more. So we just gave one odd transfusion and then we were done. Now that I have delivered this patient, because she has that much of anti-D in her own body, would you like to give her anti-D, madam, after delivery to the mother? No, not really, because she has anti-D in her, right? She can donate anti-D. So I would not like to give anti-D here. Never. I mean, I was just joking. I was saying that she has INTD, so there is no point in giving. Yes. So, yeah. So postnatal blood transfusions to the baby. If Tushar sir and ma'am, if you want to tell us more about transfusion to the baby after delivery. So as you know, baby's blood group is going to be exactly. Yes.
Leukodepleted, irradiated, hemoconcentrated, extended cross-match preferably. This is the kind of blood we would like to give to the baby.
Absolutely, and they do need postnatal blood transfusions as well.
Sometimes even phototherapy is required.
And phototherapy also almost always
Yes.
they need, because usually they are delivered prematurely. Usually they have lots of hemolysis going on in their system, and their bone marrow is asleep. There is hypoplasia of bone marrow because of repeated blood transfusions. So baby needs like 3 months almost to start reviving its bone marrow. Till that time, they require blood transfusion. Typically, patients come from periphery, they are managed there. And on day 1, I get a call from the pediatrician, baby ka blood group to negative tha, itne baar kyun diya blood transfusion? Baby ka blood group negative nahi tha, maine kiya hai wo. I've given O negative blood, right? So you're going to test baby's blood group at 6 months, not right now. So that is about that.
So about 3 to 3.5 months, the baby starts producing.
Yes, ma'am.
its own RBC.
Yes, ma'am.
That's the main point.
Yeah. Till that time, they need
That time they require blood transfusion.
absolutely. So they need very close monitoring with
How
the
frequently
neonatologist.
we can transfer uterine?
Um,
Intrauterine
usually with rhesus isoimmunization, you would need like 2 to 5.
2 to 5.
I usually don't transfuse anymore beyond 32 weeks because we have good NICU, so they take care of it.
With the interval of transfusion?
That is decided by the fetus. So as the MCA, so what we do is once we have transfused, we keep monitoring them with MCA PSV, middle cerebral artery peak systolic velocity, which has 99% sensitivity for fetal anemia. So it is a very good test, non-invasive. So gone are Lilly charts and everything else now. We just go by MCA PSV. And if MCA PSV shows fetal anemia, we transfuse. We don't want babies to be in hydrops.
Yeah.
Hydropic baby is very difficult to manage. We could save this baby, but that was lucky. So
Fluid everywhere.
exactly. So I don't have actually post-transfusion pictures. 3 days after, hydrops was gone. So it was very, very useful.
Baby grew also properly.
Yeah, baby is now 4.
37 weeks.
Baby is now 4 years old. So now, if I am not dealing with isoimmunized case, I have a rhesus negative mother who is not isoimmunized, sir. So when should I be doing ICT for her?
ICT should be done at 28 weeks
Yes, sir.
compulsory.
Yes.
And then we should go for whether it is a rising titer or not.
Yes.
Then actually we should calculate how much amount of anti-AT dose to be given.
Yes.
So we should go for the or
Yes, sir.
bed case test.
Yes. Yes.
So that's a very simple test, but it is not done in every lab.
Yes, sir. So
Because
for Clear
probably-
will come in a minute. If I'll just finish off antenatal anti-D because now we have obstetricians here. So, ma'am, if you want to tell us more about antenatal anti-D, when do you give it? How do you give it?
Antenatal anti-D we give at 28 weeks and after the delivery.
Absolutely. And every time when there is bleeding. So if rhesus negative mother comes with a bleeding, we should give anti-D unless the bleeding episode is less than 15 days apart. So 15 दिवसापूर्वीच दिलं असेल तर म्हणजे 15 दिवसापेक्षा कमी दिलं असेल तर you should give it. Otherwise, there is no need to give anti-D. But yes, as ma'am rightly said, bleeding episodes 28 weeks. So 28 weeks is called RAADP, routine antenatal anti-D prophylaxis, which is the standard of care now. So everybody should get it. After delivery, as sir was mentioning, we should always be doing a Clyhor test before we give anti-D. When was the last time you ordered Clyhor, ma'am? Because it is not available routinely. I've asked so many labs and it is not available. So Tushar sir, if you want to tell us more about that.
So basically Clyhor test is not demanded from the clinician, so probably it is not made available by the
Oh, all
lab.
right.
So because in India, the Rh negativity percentage is very low
Yes.
compared to the Western
Western
countries.
world.
So we have 5% only Rh negative. Then we have got NTD available. So people don't want basically
True.
to calculate the dose and why not to go for the test.
True.
But if at all clinician wants to go for to calculate the dose of NTD, then there is a clear or bed case test.
Yeah.
So basically, it's a simple test that is based on principle of acid elution technique.
Yes.
Because there is an exchange of the baby's blood into maternal circulation.
Yes.
So if you take the mother's blood sample and we are making the smear,
Yes.
and on that smear, if you treat the smear with the acid, hydrochloric acid in various percentage, so the fetal RBCs, which contains the HbF,
Oh,
which is resistant for acid elution.
yes.
But the adult hemoglobin, that is hemoglobin A, 0 and A1,
Mhm.
so that gets lysed.
Oh.
So all those adult RBCs containing HbA will get lysed and they appear as a ghost cells.
Oh.
While those RBCs which are containing the fetal hemoglobin, they will take pink color because counterstain we use as a eosin.
Oh.
So all those pink cells we have to measure under the microscope.
Right.
So we take the percentage of fetal RBCs divided by the mother RBCs.
Yes.
So we take condition that we should count at least 2000 RBCs
Yes.
before we come to the ratio. So we take the ratio of fetal RBCs upon maternal RBCs multiplied by the maternal blood volume, that is 1800 ml, multiplied by a factor 1.22,
Mhm.
and we get ultimate result in terms of ml of blood.
Oh.
That is an fetal-maternal bleed of dash dash ml.
Oh.
So basically, for sensitization, very small amount of blood is necessary. As book says, 0.01 ml to 0.03 ml is sufficient
Oh.
for sensitization. But if you want to calculate the dose of NTD,
Mhm.
then we have to calculate by this formula
Yes.
the fetal-maternal hemorrhage. 125 international units of NTD will neutralize the 1 ml
Oh.
of fetal blood.
Right.
So accordingly, we should calculate the dose of NTD from the result.
Yes. So
And
our
we should
usual vial of 300 microgram, that is 1500 international units,
Minutes,
would usually cover 12 ml of
12
blood.
ml of fetal blood.
Oh. Oh. And in other words, 1 ml of 1% of patients will not be covered, and we are talking about patients who are delivered vaginally. With cesarean, with twins, there would be more fetal-maternal hemorrhage. So probably CLAR for all should be the way
So in
forward.
case there is a history of trauma, patient get history of fall,
Yes.
or there is some procedure interventions,
Yes.
then there are chances of fetal-maternal hemorrhage. So we might require more dose. So
Absolutely.
that has to be-
Thank you, sir. That really helps. Because we are talking about transfusion, I mean, talking from the platform of JANAKALYAN and IMA here, and NTD is not just another injection, it is a blood product, isn't it? So if you want to tell us more about prion diseases, which can potentially be transmitted through NTD and how to reduce them. So prions are viral particles.
They're not viral also. They're just
Yeah.
DNA particles.
Yeah.
And I'm not the best person to answer how to reduce them. I would want Dr. Tanvi to take over.
Right. Right. So the only way.
Yeah, hello.
Yeah.
Yeah. So not really from our end, if sir or if anybody else has remarks about it this prior.
Prevalent in our setup.
Right.
It is more prevalent in the UK.
Yes.
That is why they are doing the testing for prion compulsory
Yes.
in the donor's blood test.
Right. Right.
In India, we don't.
Yes. Yes. And there were like 4 or 5 cases of fetal prion from one particular center which manufactured NTD out of Ireland. And that is how it became a big sensation there. I mean, I think we'll need somebody else.
So
to-
I think the best way is to just monitor whoever is donating the
Absolutely.
NTD.
Absolutely.
In that case,
I'm-
we'll have to monitor whoever's donating the blood for the fetus also.
Precisely, and irradiation would help. Irradiation would help, and I was about to come to that. Would you be recommending irradiation for all bloods?
Universal irradiation is a concept, but it is not indicated for all patients.
Right.
The adult patients who
Repeated.
electively would need blood on 1 or 2 occasions, they would definitely not need irradiated blood.
Right.
But for special cases, especially intrauterine or specifically when we know patient is immunocompromised, so
Right.
in such cases, it will be better covered in the next session, I think, recent
perfect.
advances of transfusion. So,
Perfect.
but specifically intrauterine, definitely
Right.
we have to go for irradiation.
Yes. And one way of avoiding anti-D injections is actually testing fetal blood group. And now that is possible by a simple test called NIPT. We take mother's blood and we can potentially do fetal blood group. Not all NIPTs can do that. Until recently, only one NIPT out of Delhi could do it if you provided fresh maternal blood. So I had an American patient who knew so much about prions and she wanted to avoid anti-D injection if possible. She traveled all the way to Delhi, gave her blood, did an NIPT, fetus was rhesus negative, and then she did not take anti-D. Now, soon enough, commercial NIPT for fetal blood will be available by one of the reputed labs in Mumbai, and they'll be making it available nationally. So once that happens, potentially you could offer NIPT, check for fetal blood, and then only decide antenatal anti-D. And that. No, so NIPT for all. Rhesus negative patient comes in, do NIPT, you know fetal blood group. Whichever time she bleeds,
So
you're not
if
worried. You're
she's
not going to give
negative,
anti-D.
If the fetus is negative, you're not
Yeah.
worried.
Yeah. So that will make our job much easier.
But then even if the fetus is negative, let's say she's conceiving for the first time, you would still want to do NTD because what if she conceives the next time and it is positive?
No, no. So this anti-D injection will protect her only for this pregnancy, right?
No. About the next pregnancies also we will have to think, no?
No, so next pregnancy will again do NIPT
Acha.
with that fetus. Anyways, we have started doing NIPT for trisomy 21 Down syndrome now. So we can just extend the panel now. So it becomes easier. Not everybody, no, not everybody. So we offer either a good quality dual marker or an extended test called enhanced first trimester, which also gives many other, so preeclampsia, fetal growth restriction, premature births, diabetes. You can, so now we have a program called 12 at 12. You can screen for 12 conditions at 12 weeks. So we do that now. So I think we have, sir has very nicely explained everything about Clahor so far. So I think we can skip that. If you just want to tell us about role of Clahor in rhesus positive patients, should we be ordering Clahor for rhesus positive?
Yes, you can.
Yes.
There is for trauma and other things.
Absolutely. So it's very interesting to know that one of the causes of stillbirths is fetal-maternal hemorrhage, and that can be picked up with reduced fetal movements if you do Clahor, and if that shows fetal-maternal hemorrhage, time to deliver. Similarly, if there is maternal trauma, you want to know if there is fetal-maternal hemorrhage, you can order Clahor. So Clahor is a very useful test, and we should be ordering it more and more, not only for rhesus negative, but also for rhesus positive. Then I'm going to just request her to tell us about antibody screening in rhesus positive patients. Should we be offering ICT for them, and what are the advantages?
So once ICT is positive in absence of RH isoimmunization, the chances that is minor blood group antibody basically.
Yes.
The patient has exposed to those
Yes.
minor blood group.
Absolutely. Absolutely.
In RH positive.
Yes.
So rare means the patient baby is having hydrops, then we go in for a ICT.
No, so
Or
global
it is the way,
guidelines,
yeah.
global guidelines suggest that it is not only blood grouping, but antibody screening for all at booking and again at 28 weeks. So antibody screening is something which we miss out on. So yes, then I think obstetric hemorrhage, we'll just quickly go through the basic obstetric hemorrhage and just routine management, which everybody should know because people can deliver anywhere. So 32 years old, second para, delivered after 6 hours of labor, so precipitate labor. 3.4 kilo male baby, placenta was delivered by controlled contraction, uterus was flabby, patient started bleeding heavily, approximately 1 liter blood loss. So Meenakshi ma'am, what would you like to do?
The first step is whether it is a traumatic PPH or it is an atonic PPH, because this is a story of PPH. The story of PPH is now well known to everybody because of that case of Archana Sharma.
So true.
And yes, so if the patient is losing 1 liter of blood, it might be a traumatic PPH because some arterial, some cervical artery maybe has ruptured or it has been torn. If there is no trauma, obviously the uterus is flabby, and then oxytocin and everything has to be started. And of course, the coagulation parameters have to be sent, blood has to be cross-matched. And any normal delivery also, normally we know in today's era, we advise to cross-match 2 bottles of blood for every normal delivery, even if it
Absolutely
is a
important.
no risk.
So true.
Yeah.
And for our nursing staff to make their job easier, what we have started using on our wards is the signal system. If the readings, these are readings of blood pressure, pulse, etc. If they are in white, they are normal. If they are in yellow, you should call doctor. If they are in red, really call doctor. Right? So now Madam has beautifully explained the role of medical management. Then when should she go to the theater? By the second dose of carboprost 250 micrograms, which can be given every 15 minutes apart, maximum of 8 doses. By the end of second dose, that is half an hour, she should be in the theater for exploration. I'm not going to go bore my non-obstetric audience with routine management in the theater, but what is novel? Bakri balloon. So instead of doing those painful massages on the uterine tummy, now we have started using these balloons. They're super expensive, but a lady from Jharkhand has come out with an alternative. This has been taken over by WHO as a patent and made available free of cost to the entire world. And this is made from Follies. Commercially available Bakri balloon, 10,000 rupees. And this is 2 Follies catheters. So yes, we can work the things effectively. And other thing which we have done is to simplify record keeping. We already have printed PPH forms, so people can just start ticking off. Kaun kab aaya, kisne kya kiya, kaun sa injection diya, everything is there. So medical legally you can protect yourself, because missing swabs, wrong injections, wrong sampling, all of that will happen more rampantly when you are panicking, when your patient is bleeding to death. So while we are talking about sampling, do you want to tell us more about, so on one side we are giving her fluids and we also want blood. So what precautions should we take?
Basically in massive bleeding, clinicians are preferring the use of colloids.
Yes, sir.
So before use of colloid, our suggestion will be they should take the sample before they start the colloid, because that will create a problem in our blood bank grouping and cross matching. So we'll advise they should take an extra sample of at least 2 EDTA containers and 2 plain containers.
Yes.
Keep it is separate, and they can start the resuscitation as in fluid management till the blood is available.
Great.
So that will be useful for the patient. If in case in future, if patient bleeds a lot and she will require massive transfusions.
Yes, sir.
So that time it will be helpful for grouping and cross matching.
Great. Thank you so much, sir. And I think that is a very important point, that before you start your colloids, sample the blood so that you don't interfere with cross matching. Otherwise, you may have wrong blood grouping. There are different surgical techniques which are essential for in the armamentarium of a competent high-risk obstetrician, right from uterine artery to internal iliac ligation, B-Lynch sutures, and this is called as systematic devascularization procedures. End of it being aortic clamping till you do obstetric hysterectomy. But now, if you know that you have a high-risk patient, we have got novel alternatives. So this was a case which we did for aplastic anemia. She had a myelofibrosis, triple negative disease. Blood was reserved with JANAKALYAN, and on the request of hematologist, we delivered that patient at 30 weeks. What we did is we got an interventional radiologist to put in the internal iliac balloons in cath lab while she was pregnant. So that much exposure to the fetus is acceptable. Then the patient was taken to the cesarean theater. I started with the cesarean, and the moment I clamped the cord, he inflated the balloons. I delivered the baby, delivered the placenta, sutured the uterus. He removed the balloons and did uterine artery embolization in the theater itself under C-arm. And the total blood loss is on the left of your screen. Total 5 half-soaked mobs. Usually, we would require 12 or 15 units of bloods. So there was no blood loss. We could conserve the uterus, conserve the patient very safely. Unfortunately, her disease, she succumbed to that later on. But there was no surgical mortality. That was, we were happy about. So many thanks for your patient listening. May I request our esteemed panel to give concluding remarks, and then we'll stop.
Concluding remarks, at least for me as an obstetrician, to keep 2 bottles of blood reserved for every delivery patient whenever she comes in labor. That is to safeguard your practice and also to safeguard your patient, and also keep that blood bottles. You have to extend if the patient doesn't deliver by say 2 days. The blood bottles have to be extended, and that usually the obstetricians forget, because they reserve the blood and then the patient sometimes takes 5 or 6 days to deliver. And by that time, the blood bottle reservation is expired.
Absolutely.
So one must be very attentive, and they should extend the reservation period of that blood bottle, which is reserved.
True, true.
My remark will be there should be good communication between the obstetricians and lab as well as the blood bank persons.
So true.
That will be more helpful.
For the PPH, call some help from your colleagues and manage the patient very actively without losing the time to save the mother and baby.
Yes.
That is the important.
For PPH, I would just like to add one more thing. If a massive transfusion is foreseen, it's not just the blood that we are to replace. Coagulation, transfusion coagulopathy also should be kept in mind. And if needed, FFP and platelets might be needed if massive transfusions are foreseen.
And that's a very important lesson. Now, post-Iraq war, our guidelines have slightly changed. Initially, we used to give 4-1-1, 4 PCVs, 1 FFP, 1 plasma. Now we give 1-1-1. So
And
that's very
there are
important.
now these indexes and calculators where you just enter the amount of blood loss and the procedure and everything, and you can predict whether this is a massive transfusion required or not. And based on that, you don't need to wait for 6 hours as per the previous guidelines to call it a massive transfusion. You can just predict and start the transfusion with 1:1:1 ratio.
Absolutely. Thank you so much. Thanks for your participation, impromptu participation, that too. And thanks IMA and JANAKALYAN for giving us this opportunity. Thank you so much.
Thank you. So thank you for our both the presidents, present president and past president. So it was a wonderful. Otherwise, I think Umarji and
Actually, Umarji has done it very well.
Very
last
well.
Minute,
Yeah,
if
last
three
minute.
panelists have not come.
Yeah,
it is the duty
yeah,
of the
yeah.
moderator. To carry
Moderator.
on.
So it's a obstetrician duty. So well done, Chinmay. So now I'll request our president, Madam Dr. Meenakshi Deshpande, to felicitate Dr. Chinmay Umarji, moderator, and Dr. Tushar Patil, one of the panelists.
You have done the job without
Yeah. Medicine specialist. And everyone must visit his new that mother and child care hospital at Baner. It's a real modern. Thank you, Chinmay and Dr. Tushar Patil, sir. And thank you, Dr. Meenakshi Deshpande, madam, and Dr. Aarti Nimkar, you are the last minute panelist. So thank you. Now I hand over the mic to Dr. Gitanjali Sharma for the next panel discussion conduction.
Before I invite the panelists for the next session, let me remind you of EveCon. That is our conference coming up on 27th and 28th of August. I request all the IMA members, ladies and gents, to enroll for this conference. It's not just academics, but there are a lot of cultural activities and competitions. Various team IMAs are participating and there will be competition among the teams. So this is an announcement of EveCon as well as a request to all of you to register for EveCon. Yeah, the brochures are kept outside, so you can collect the brochures from there. Now, may I request moderator for the next session, Dr. Shashikant Patil, to come on to the dais, please. The theme or the topic is transfusion medicine updates for clinician. That is the recent advances. We have the other panelists as Dr. Rajesh Deshpande and Dr. Atul Kulkarni. Please come on to the dais, please. I understand Dr. Bhatt sir is not available anyway. So I take this opportunity to introduce Dr. Shashikant Patil, the moderator for today's session. He is MD DNB. He is MD DNB in Immunohematology and Transfusion Medicine. He works at Jahangir Hospital, Pune. Consultant Transfusion Medicine and in charge of Blood Center. More than 9 years experience he has in this field. Special recognition, he is a gold medalist in DNB Immunohematology and Transfusion Medicine. He is winner of Harold Gunson Fellowship Award in 2016. Actively involved in clinical aspects of transfusion medicine, more than 100 TPA procedures, more than 25 PBSC collections, cryopreservation, therapeutic phlebotomy, patient blood management, etc. Voluntary blood donor motivation, and he has 3 publications. So welcome to this. Our other panel is Dr. Rajesh Deshpande. He is MD Pathology with specialization in the field of blood banking. He is working as Fresenius Kabi Asia Pacific. He's Senior Manager Medical Affairs, Transfusion and Cell Therapies Division. He has more than 25 years of experience and he has been speaker at various national and international conferences such as ISBT, EPBMT, AABB, AATM, Transcon, Transmedcon, etc. He is responsible for launch and implementation of Apheresis technology and stem cell transplantation at various sites in Asia. Dr. Atul Kulkarni needs no introduction actually. He is convener for today's program. He is director in charge of JANAKALYAN Blood Bank, Pune. MBBS Diploma in Pathology from Pune University, Diploma in Transfusion Medicine, CPS Mumbai. He is internal auditor for Blood Bank NABH, internal auditor for Hospital NABH. He is member of Governing Body and Technical Committee of SBTC Maharashtra. He is director of JANAKALYAN Chain of Blood Banks and Medical Services. He is the lead assessor for NABH for the blood banks, assessor of NABH for entry-level hospitals. His main areas of interest is quality in blood transfusion service, and he is a regular platelet donor. Great to have you all over here. And may I now hand over the mic to you.
So after much more informative sessions, now this is a big responsibility to keep everyone engaged, and that is why we have selected to talk on something interesting, something which is, I think, not routinely practiced at every hospital, but some practices which are related to transfusion medicine that we are going to talk about. But before starting, okay, so before starting all the discussion, I'd like to just brief about the history of transfusion medicine or blood banking and how the practices of blood bank now are going into transfusion medicine practice, or they are rather called as transfusion medicine sector. Actually, it all started in 20th century, at the very start of 20th century, when blood group were discovered by Professor Karl Landsteiner. And before that, many trials were done to transfuse human to human blood, but actual blood transfusion started when the blood groups were discovered. Slowly, there was discovery and use of anticoagulant solution, which was practiced in both the world wars. And then there came use of plasticizers for storage of blood. Later on, we observed many transmission of transfusion transmitted diseases such as HIV or hepatitis into the patient, and slowly testing of blood for various diseases developed. Then it was understood that blood is only a raw material. Actually, it contains a lot of things such as platelets, plasma. We also need coagulation factors in the plasma, red cells, and later on the development of component therapy, it started. Going ahead, at the start of 21st century, actually some modified blood components were developed. It was understood that white blood cells are actually, we do not require those, though it is a part of whole blood. And we started reducing or inactivating white blood cells using leukoreduction or irradiation. We also started using platelet additive solution. And in current era, the blood bank practices have expanded their perimeter from blood bank to clinical practice, where many advanced principles are being used to give clinical benefit to the patient. One such technology is called as Apheresis technology, which is used for blood donation also, and which is also used for therapeutic purpose. There is also one more technology called as leukodepletion. There is nucleic acid testing. There are advanced immunohematology laboratory. In previous session, we heard about we heard about RH and KEL, but believe me, there are more than 40 blood groups right now. And there is Duffy blood group, there is MNS, and we need to test for those blood groups. That lab is called as Immunohematology Laboratory. Yes, we do test patients' blood for extended red cell typing, such as RH, KL, Duffy, KID, MNS, all these minor antigens we regularly now started testing. We also are performing intrauterine transfusions where specific blood component is required. We do cryopreservation, that is prolonged preservation of rare blood groups such as Bombay blood groups. By using the method called as cryopreservation, we preserve stem cells of patient at the time of bone marrow transplant, and many much more things are happening. So we'd like to touch upon briefly on some of these advanced or recent clinical updates of transfusion medicine with the help of few cases. So our first case is a 29-year-old female, was teacher by occupation, no history of diabetes, hypertension or any other major medical illness and surgical illness. She came with lower limb weakness since 5 to 6 days, which was sudden onset, started as tingling and numbness in toes and fingers, initially at lower limbs, then progressed to upper limb and torso, resulting in inability to walk, followed by difficulty in breathing. In CNS examination, she was conscious oriented. There was mild dysarthria. The power in the upper and lower limb was 1/5. Reflexes were absent. There was sensory loss for for large fibers and small fibers in both the limbs. Other systems were normal. Her CSF showed cytoalbuminological dissociation. Electrolytes were normal. Nerve conduction study showed sensory motor neuropathy. which was demyelinating plus axonal in both upper and lower limb. So actually, Dr. Shripad Bhatt was one of our panelists, but I would like to request Dr. Deshpande sir, what kind of what can be or more likely diagnosis of this patient, and what can be the further management of this patient?
So this case primarily is GB syndrome. So we know that Guillain-Barré syndrome is one of the common cases which are seen in neurological conditions. And the main treatment for GB syndrome primarily could be either give IVIG or immunoglobulins or a therapeutic plasma exchange. So these are the two main options when we talk of treatment. Now, to decide which treatment would you prefer, it depends upon, the available. One is the availability, whether we are able to provide immunoglobulin treatment to the patient or not, how affordable it is. That's the first thing. And the second option is to use therapeutic plasma exchange, because therapeutic plasma exchange in this case has a very good prognosis. And secondly, it is considered to be a category 1 indication for ASFA guidelines. ASFA is the American Society for Apheresis guidelines. So ASFA releases guidelines for therapeutic apheresis every 3 years, and they keep on updating depending upon the various clinical trials and data which they get globally. And so they divide the various indications in different categories. Category 1 is where therapeutic apheresis is considered as a primary line of treatment, and GB syndrome or even myasthenia gravis and certain other neurological indications and nephrological indications also, like glomerulosclerosis and all, they all come in category 1 indication where therapeutic apheresis benefits a lot to this patient. So I would say that the best option here would be to give therapeutic apheresis.
Right, so therapeutic apheresis and especially therapeutic plasma exchange. So this patient was treated for 5 cycles of therapeutic plasma exchange. We calculated her blood volume, which came out to be 5,300 ml. And we also calculated the plasma volume of the patient. And we tried to replace 1 to 1.5 plasma volume. Particularly in this case, 1 to 1.2 plasma volume was replaced in 1 cycle. And similarly, we exchanged 1 to 1.5 plasma volume for 5 times a day, and patient was discharged on 7th day. The total cost was also quite minimal. It included only kit cost and plasma cost, but it was quite cheaper as compared to IVIG, because in elderly patient the cost of IVIG, it goes according to patient's body weight, and it goes means in lakhs. So as sir very clearly said that there are category of indications. So mainly category 1 and category 2 patient, they get benefited by therapeutic plasma exchange quite well. So there are other indications, like this is only neurological case which we discussed, but therapeutic plasma exchange is beneficial in many specialties or almost in all specialties. For example, in neurology, it is used for AIDP or CIDP, or for myasthenia gravis or polyneuropathy associated with paraproteinemia. In hematology, TTP cases benefit a lot by using therapeutic plasma exchange. Also hyperviscosity syndromes or severe cryoglobulinemia. These patients also, and patients of a typical HUS, hemolytic uremic syndromes, they also have very good benefit after plasma exchange therapy. In renals, Goodpasture syndrome, in renal system, Goodpasture syndrome or ANCA associated rapidly progressive glomerulonephritis, antibody mediated renal transplant rejection. So this is actually one of the most common reason where the renal transplant gets rejected because of the antibodies, and regular plasma exchange helps to preserve that graft. And in many metabolic diseases such as familial hypercholesterolemia, plasma exchange, actually wherever the pathology lies in plasma, and if you want to remove that pathological agent, the plasma exchange therapies now can be considered. But doing this plasma exchange therapy requires some technology, requires some specialized machines. One machine or one technology which is now available and recently developed, and Dr. Deshpande sir has done a lot in this area, is apheresis technology. So sir, I would like to ask you, what is this apheresis? What is this principle of apheresis machine, and how much it is safe for the patient?
Okay. So apheresis basically is a concept where we are trying to remove a particular component of the patient's body and return back the remaining. Like it's coming from a Greek word apheresis, which means remove or take away, where we are using a particular device to process the patient's blood or the donor's blood also. Where the blood comes out from the patient or the donor, it goes inside the machine. Suppose we want to remove a particular component, that particular component is removed and retained in the disposable set of the machine, and the remaining blood joins and goes back to the body of the patient. So that is apheresis. Now, when we talk of apheresis, we primarily divide it into two types. One is the centrifugal method, where it depends upon the density or of the various components. So if the red cells, as we can see here, red cells are heavy, they settle down, followed by the leukocytes, then the platelets and the plasma. So, and once they settle down at different layers, we are able to separate out the various components and remove whatever desired component we need to remove. Similarly, we can also use filtration, where filtration separates out the plasma and cells. So if you're doing plasmapheresis, whether it's donor or patient related, you can also use filtration, where we are able to remove the plasma out. Then as we move ahead, we can see that this is the centrifugal apheresis, which we call it a vein-to-vein procedure, where the blood is coming out from the vein of the donor or the patient. It goes in the machine. It is separated by the principle of centrifugation. The various components are then collected, whichever you want. The remaining will join and again go back in the vein of the patient or the donor. So we are saying we start from the vein, we go back to the vein. Then there are different types in this centrifugal apheresis. One is the intermittent flow system and a continuous flow system. Intermittent flow is basically the machines which are using a ball technology, and they perform single arm procedures usually, where the blood is coming out, goes in the bowl has to fill up, then it starts moving or centrifuging. The various components are separated, returned, and then restarted again. So it's intermittent. You have a draw cycle, you have a return cycle. So it takes much longer, especially if you're doing TPE or stem cell collection. This intermittent flow procedure takes longer time. The extracorporeal volume outside is much more. The only advantage here you would say is a single arm procedure. Here one arm is free. The other option is continuous flow technology, where it can go on in continuous separation and collection, where blood is coming out from one arm, going in the machine, separating and returning simultaneously. So we are maintaining the fluid balance. So in this case, when you're doing TPE or stem cell or leukapheresis, you may find that you have to use both the hands, but it is much faster and the isovolumic status of the patient is maintained.
Right, sir. So as sir said that we are removing some amount of blood from patient. We are trying to separate the different blood components, whichever is required to be removed or collected, and rest we are sending back to the patient. So what are the applications of this technology? Sir, I would like to highlight that whether it can be used for donor apheresis, and also it can be used for therapeutic apheresis. So Dr. Deshpande sir, if you can elaborate on various uses of this technology.
Sure. Yeah, so donor apheresis is basically where we are connecting a healthy donor and we are collecting a component that we require. For instance, everybody is aware of platelet pheresis, right? There are many platelet donors, and I'm sure some of you would also be platelet donor, like Dr. Atul Kulkarni we have, who is a regular platelet donor. So, so it's a healthy donor coming and donating his platelets, which are used for a patient. This is the most common donor apheresis. You can also donate plasma. In certain countries, there are red cells which are being donated, from healthy donors. Then you can donate stem cells. So all these are donor apheresis. Then therapeutic apheresis is where you can see in the picture itself that it's a patient or who's connected to the device. So we are performing a procedure where we are trying to remove pathologic components from a patient, like the next slide. Yeah, so these are the list of various procedures. As I already mentioned, the donor apheresis ones. So therapeutic procedures, there are plenty. We have therapeutic plasma exchange, where we are removing the plasma of the diseased patient and replacing it with fresh plasma or albumin. There is a specialized procedure on the plasma also. We call it immunoadsorption, where the same plasma is purified with the help of a column or a filter and given back to the patient. So you don't have to give him anything additional or separate. You just purify his plasma and give it back. That's called immunoadsorption. It's a very expensive procedure because the column or the filter that you need to purify the plasma is expensive and not easily available. Then there is red cell exchange, which is given in sickle cell anemia or malaria, where you are removing the diseased red cells and replacing them with normal red cells. Then you have white cell collections or granulocyte collections you have. Then you have leukapheresis, where in patients with high leukemic index or cells, you can put them on the machine and you remove those high counts of white cells and help the patients. But you need to do these procedures very often.
Right, sir.
So this is in short, if you can see the slide, is an entire list of all therapeutic apheresis procedures which are available. You can see there is plasma exchange, then you have the cytopheresis, where you can have different cells, whether it's white cells, platelets or red cells removal. Then there is stem cell harvesting, where we are collecting stem cells. So stem cell treatment is also, picked up very well in India, and we have people going for various autologous and allogenic stem cell transplantation. Then there is something called online processing, where, as I mentioned, it's immunoadsorption. We are processing and purifying the plasma and giving back. And there is something called ECP also, which has come called extracorporeal photopheresis. We are collecting the white cells, we are exposing them to UV light. You are, let's say, manipulating those cells and giving it back to the patient so that these cells will go and attack the tumor cells. For instance, in Sézary syndrome or GVHD, where you use ECP. So these are the various new protocols. So a lot of new things are happening here. And like something like CAR T cell therapy is coming nowadays, where we are removing the lymphocytes, adding a vector to them, creating new cells, and re-infusing back to the patient. So much of things are happening in terms of the apheresis now.
Right. So I think the 20th and 21st century was actually the one of the transition phase where someone has tried a dog's blood to transfuse into a human in 18th or 19th century, and now we are selectively removing some component, modifying it selectively, and using this technology for treatment of patient. So generally it uses the principle of specific gravity, where according to specific gravity, we can remove the blood components. Here I would like to show a video of plasmapheresis, so you can have a visual impression of how this machine works. मी बोले साउंड शेयर करते हैं. So this is apheresis machine, a discontinuous type or intermittent type. Online survey. Stop share करायला पाहिजे. मागे करा, मागे करा. Hello. So this is apheresis machine. Here we can see that the access, peripheral venous access is taken from internal jugular vein, and this disposable kit is attached to the machine. At a time, around 200 to 300 ml of blood is taken into the circuit in this draw cycle, as it is intermittent machine. Simultaneously, one anticoagulant solution is being added over here. This is the replacement plasma which we are going to give through this circuit. This anticoagulant solution keeps whole blood or whole system in anticoagulated state, so that the blood, all blood components are processed. This is the centrifuge, where blood components are centrifuged. If the lights are off, they can see. So here you can see that the blood components are being centrifuged and different blood components are separated according to its specific gravity. And here you can see the plasma of patient which is collected in the bag which is attached to that side. So here you can see that the plasma is being removed. So for this patient, we try to remove 2700 to 2800 ml of plasma. Next slide. Screen share झाली. Right, so here you can see that this much amount of plasma. This plasma pheresis we tried for a liver transplant patient who was in early organ dysfunction, early allograft dysfunction. These patients means therapeutic plasma exchange can be used very effectively where we need to remove the pathology which is present in plasma. So can therapeutic plasma exchange be done by using dialysis machine? What is the difference between the plasma exchange by dialysis and by apheresis? Actually, the two simultaneous principles are right now being practiced by many clinicians. So Dr. Rajesh Deshpande, if you can highlight something on this.
So basically there are two types of therapeutic apheresis. One is, as I said, the centrifugal apheresis, which is performed with the help of apheresis machines and using the separation with the help of density or specific gravity. So you can see here that the blood is coming out, going in the machine. Anticoagulant is added on the way, and then the waste is the where the plasma goes in, and then the replacement fluid joins the red cells and goes back to the body of the patient. So this is centrifugal, whereas in the membrane filtration, you see there is a filter in between. There is no centrifuge machine, but the blood comes in, goes over the pump, mixes with the anticoagulant and goes through the first filter. It separates out the plasma and the red cell. Then there is a second filter which helps you to again separate, and finally the replacement plasma joins with the red cells and goes back. So this is the membrane filtration. Now, membrane filtration is basically used in various renal machines, the dialysis machines or the CRRT machines which are there. So often we see that, in many centers, because the dialysis machines are already existing at the particular hospital, they try to use the dialysis machines for performing therapeutic apheresis. And while the centrifugal technique is basically used in apheresis machines, cell separators we call it. So that's where they're using centrifugal apheresis. Yeah. So when we talk of the difference between two, this was a nice article which was published in the Journal of Clinical Apheresis, which separated out the various features of both centrifugal and membrane. Membrane TP is the one we call, which is used on dialysis. And you can see that normally we use heparin for dialysis, whereas in centrifugal we use the anticoagulant ACD. And the main advantage here is that we are able to perform with lower flow rates. In dialysis, you need a very high flow rate. We need to process more than 3 times the blood volume needs to be processed, and efficiency is only about 30%, right? So you need to process more, but what efficiency or what much of plasma which is extracted is much less. And secondly, you always need a central line. Whereas when you are performing with centrifugal technique, you can perform inside the blood center itself. You go to the blood, if the patient is ambulatory, he can walk and go inside the blood bank. He can sit on the machine and it is performed with the peripheral technology. We can go with lower flow rates because sometimes the patients don't have good veins. Their already veins are bad and they have multiple procedures being performed. So the flow rates are challenges, or even low weight patients have flow challenges. So you can do peripheral flow rates. Then you need to, and then amount of processing is just 1.5 times the blood volume, and the extraction is much more. You can even extract 80% of the plasma. So that is a very effective. Secondly, there are certain studies where you can see that the number of incidents of reactions is much less in the centrifugal or apheresis technology as compared to the dialysis one. This is also another paper which says that the amount of plasma which is removed is much more with the apheresis machines rather than dialysis machines. Yeah, this one also paper talks about that the effect of anticoagulation or side effects are much more in the membrane TPE as against the centrifugal apheresis. Yeah, and this also paper we talks about that with the dialysis machine, we are able to extract the cells, the molecular weight up to a particular size only, because we are using a filtration technology. So we cannot remove certain cells which are of a particular molecular size. Whereas when we are using apheresis technology, where basically the separation is by density, we are able to extract much more. So even various molecular weights, sometimes when you are removing plasma, we have to remove certain high molecular weight molecules which are or proteins and all which are present in the plasma, which is not possible with the filtration technology, but it's possible with the centrifugal apheresis. So as you can see here, it's very effective or very advantageous, not only for the procedural efficiency perspective, but also from the patient benefits to perform centrifugal or apheresis.
Right, sir. So for large molecules, we will go for therapeutic plasma exchange using apheresis. Large molecule includes if our pathologic molecules are if they are IgG or IgM antibodies. But to remove the small molecules like creatinine and other things, we may go with membranous principle, that is dialysis. So in short, the centrifugation principle has quite a good advantage over membranous as far as patient safety and other things are concerned, and efficacy is concerned. We use this apheresis technology quite well in our second wave, especially second wave, because use of convalescent plasma was quite highlighted at that time. Many patients benefited. So I'd like to request Dr. Kulkarni sir to share your experience, because you were involved in both the areas like collection of apheresis plasma or collection of convalescent plasma, and also you observed some patients who got benefited. So sir, briefly if you can share your experience.
Thank you, Shashikant. I will say that we are JANAKALYAN was engaged with this convalescent plasma from first wave also, in association with Kashibai Navle Medical College. We have participated in the ICMR trial, and though Dr. Shripad is not there, our center and one more center in India, both the results were proof for convalescent plasma as compared to other centers. So our experience was different, though there were different guidelines and discussion going on about convalescent plasma. At my center, our experience started before the guidelines comes, and we tried that plasma for a medico's father. He was a MD medicine student. His father was admitted, I won't declare, in a general hospital, and they have tried all the drug management. And as a last resort, they were exploring possibility of use of convalescent plasma, and they approached me. We thought, let us give a trial. And the donor was again a resident from the same medical college. We collected the convalescent plasma and tried, and it worked very well. And that boosted our confidence that we should try this technology, this modality for managing the patient. And then we engaged with the ICMR trial also. So the convalescent plasma donation is similar to any other donor apheresis technique like platelet donation or something like that. We were drawing around 500 ml of plasma, and at that time 201 unit was issued to the patient. And so around at my center we have done around 500 convalescent plasma collection procedures and issued more than 1,000 units. In second wave, what we can say, we will be able to track the antibodies. We will be able to get the idea about development of idea antibodies. And then what we feel and is that the precision has improved, and then it was used in various places. So my experience along with Navli, it was very good. The patients came out rapidly, and definitely the guidelines, as you saw, there was a panic, and as a last resort in most of the cases, they were trying for the convalescent plasma. That was a wrong practice actually, and those were actually cases whom we should not give convalescent plasma in the initial phase, where they might need ventilatory support, and at that phase only, if you could able to give the convalescent plasma, then it was helpful. So
Especially
that
in
was
first 10 days.
yeah.
Actually, it was indicated, especially in first week or second week.
Correct. So that was the thing, and then the scenario changed, and it was a rampant use. It was a misuse also by some center, and hence it has come into gray zone. But with a true proper selection of donor, antibody detection, titration, selection, and transfusion at a appropriate time. What our observation, it has worked well. Though it is not a magic drug, that was definitely we should think of it is not a magic drug, but it has worked as far as our experience is concerned.
Right, sir. Means Apheresis technology helped in COVID waves also, and not to forget, or it must be important here to mention that any donor who has recovered from COVID, he must be feeling very weak. He must be compromised somewhere or other, because this donation was possible after only 28 days of recovery. So apheresis technology was safe in that case also, when a patient who has recovered but who is yet to recover from that weakness. I think our technology helped to collect plasma very safely from those compromised donors also. Right, sir. So here I'd like to go for the next case. Actually, in our practice, when I started my MD in transfusion medicine, the first thing which I was taught was no transfusion is best transfusion. So I would like to highlight some of the areas where the transfusion reactions do occur, and would like to highlight what need to be done to prevent these cases. So with the help of next case, I would like to highlight those important points. So he is a 71-year-old male admitted at hospital due to prolonged INR, that is around 13. The patient had history of coronary artery bypass grafting for coronary artery disease and mitral valve replacement 14 years earlier. Since then, he was treated with acinocomeral. On admission, the patient was hemodynamically stable with normal vital signs. The decision to transfuse FFP was taken in order to correct the prolonged INR. FFP transfusion was uneventful and repeat INR was scheduled. But 4 hours after FFP transfusion, the patient had sudden onset of dyspnea, tachypnea, cyanosis. His saturation was below 75%. Blood pressure was 150/90. Temperature was normal. On physical examination, breath sounds were markedly decreased. There was diffuse crackles heard. There were no signs of volume overload, and his jugular venous pressure was normal. His 2D-CO was normal. ECG was normal. Cardiac enzymes were also within normal limit. His CBC showed elevated WBC at 4 hours after transfusion, which was actually normal at the time of admission. The platelet count was low, and chest radiograph showed coarse alveolar infiltrates and normal cardiac CLOT, finding that are indicative of non-cardiogenic pulmonary edema. So, Dr. Kulkarni sir, what is the probable diagnosis of this clinical event which occurred 4 hours after transfusion of FFP, and how it can be prevented?
As you have enumerated, it they have emphasized and ruled out the cardiogenic nature. So there it's a non-cardiogenic. Then it's a pulmonary edema. And also there is a history of 4 FFP transfusion. Then it's the reaction came out in 4 hours of transfusion. So on all this background, the picture, what we are suggesting is going towards TRALI, that is a transfusion related acute lung injury. So it's he has shown the photograph also. Yeah, TRALI chest X-ray. So it's showing about the non-cardiogenic pulmonary edema, and I think in the morning half also we have touched to this TRALI. So this is again one of the you can say fatal kind of transfusion reaction that you can come across after blood transfusion, and hence we are worried, and in numerous panel discussion we were focusing that we should transfuse blood or blood component whenever it is absolutely necessary. So most important thing to prevent is don't transfuse. So when it is absolutely necessary, then and then to transfuse is the best policy that we have to think of. I will not go in detail of pathophysiology. In the morning also we have discussed that there are some antibodies in the plasma that are developed because of either multiple transfusion, or if it's a female lady and multiparous woman. So plasma, in the plasma there are antibodies which are acting against leukocyte to the HLA antigens on the leukocyte, and those antibodies are going to activate the leukocyte or neutrophils in the donor's body, and priming and activation causing they will in turn will act on the endothelium, causing oozing and the trail of event which will lead to the pneumonia, interstitial pneumonia, alveoli getting filled with all these things. So this is how to prevent TRALI, yes, first most important thing is rational use, and that is what we were focusing whole day. So rational use of plasma, usually what we observed, plasma is the most irrationally used blood component. So with due respect, I want to comment on this. So this is what we should keep remembering. फक्त प्रोटीन कमी आहे आणि म्हणून प्लाझ्मा देत आहेत. So this is very wrong practice. It's a cheaper drug असं म्हणून पण दिलं जातं. So we should avoid ourselves. We should think of TRALI before giving any plasma transfusion. So it can be hazardous for the patient. So that is one policy, rational use. Secondly, at my center also we are following that only male donors plasma is used for clinical use. I have pressed about the antibodies that are present because of multiparasity and all these things in females. So it's a better practice not to use female plasma for routine transfusion. And that's why in this COVID also, in convalescent plasma protocol by ICMR all globally, the female donors plasma were not taken. Right. Those who are nulliparous female, only for those COVID positive we were collecting the convalescent plasma. Same logic is there. So for clinical use, try to avoid female donors plasma. At my center we are not using it. So that is a second area what how we can prevent. Yes, there is one area that is a leukodepleted blood component. Yeah, it's useful, but not for all TRALI cases. Mind well, not for all TRALI cases. Some of the TRALI are because of the leukocyte that are there in the blood and blood component. They are going and causing damage. So in those cases only leukodepletion will be helpful. So that is one. And again, some newer things coming up. If you are able to use solvent detergent treated plasma, so in those cases also it is useful and it can prevent the trolley. So practically what we can think of is a rational use of plasma. Secondly, male donor plasma for transfusion and leukodepletion. That's currently easily available methodologies with us that can be used to prevent this kind of reaction.
Exactly, sir. So this is, I just took the chance to highlight transfusion reactions can occur. So it was one of the serious case which we experienced. But please believe me that this is not the only case. There are many transfusion reactions happening in routine clinical practice, which has short-term as well as long-term impact on patients. So this is one of the list of various transfusion reactions. And in most of these transfusion reactions, which can be non-immunological or immunological, the most important contaminant or the culprit of the blood component is leukocytes. The leukocytes are involved in pathogenesis of many of these immune, non-immune, acute, delayed transfusion reactions. For example, in alumination, leukocytes are involved. In GVHD also, leukocytes are involved. In cytomegalovirus transmission, this is also occurs through leukocytes. There is immunomodulation, which is constantly occurring in multiply transfused patient. So yes, WBCs, we need blood. Blood is very precious. Blood is very life-saving. But leukocytes, they are kind of which we do not actually prefer in our blood components. So
you can say that they are worrisome blood cell.
Yeah.
As far as transfusion is considered, worrisome.
Yeah, and most of the clinicians must be experiencing lot of problems if a patient do have transfusion reactions. Actually, Dr. Bhatt was to share his experience when he had any transfusion reaction, but I think managing a transfusion reaction and how it impacts the whole clinical management of the patient and also the economical area is covered in morning session. So here we can conclude that if we encounter any transfusion reaction, it hampers everyone's routine, right? So prevention is very much important. And as we also said that leukocytes are one of the kind of unwanted factors. So I'd like to ask Dr. Rajesh Deshpande, can we do anything about these leukocytes? Can we remove them?
Yeah, yes, definitely. So now more and more blood centers, not only the big one, say the big corporate or big setup, but everyone is aware of the disadvantages of having leukocytes in the component are moving towards leukoreduction. So leukoreduction is a concept which actually for us is still new, but abroad, like if you go to Europe, then universal leukoreduction is part of it, where every component is leukoreduced. But we are still in a stage where we can, we may not be able to give leukoreduced components to each and every patient or make each and every component leukoreduced. But we can still, do whatever we can. So leukoreduction is basically we are trying to reduce the amount of leukocytes in the component like red cell or platelets to such a low value that the harmful effects of leukocytes are all minimized or avoided. That is the main function of leukocytes, because normally what happens, maximum adverse reactions are, which are there because of transfusion are because of leukocytes.
Right, sir. So there are many established benefits.
Yeah.
It can reduce the febrile non-hemolytic transfusion reaction. It can reduce CMV transmission. Believe me, around 80% of our population is CMV positive, and transmission of CMV, especially in intrauterine transfusions or in neonatal cases or immunocompromised patients, it causes a lot of problems. So leukoreduction definitely decreases CMV transmission, and it prevents and or delays the aluminization. Actually, if someone is practicing with the patients who needs to get multiple transfusion, they must have encountered the problem with aluminization against different antibodies. So leukodepleted component may prevent or delay leukocyte aluminization, right?
Yeah. And then there are various methods, like talking of the methods of performing leukoreduction is one is pre-storage or post-storage. Post-storage is something which I think most of the clinicians would also be aware which is more easily followed, is the bedside filtration, right? So many times we, especially the patients who are under treatment by hematologist or oncologist, hemato-oncologist, they need multiple transfusions. In that case, bedside filters are usually recommended, even for thalassemia for that matter. Thalassemias are multi-transfused patients who are receiving transfusions every month. So bedside filtration remains the most common form of leukoreduction. Yeah. At the same time, when we talk from a blood bank point of view, we would really advocate something called as pre-storage, where one moment you collect the blood, you separate out the components, and then you can go the process of leukoreduction, where we remove the leukocytes and keep the product ready for to be used. Because at that time, we are able to remove the leukocytes as long as they're intact. When you store the blood component over 24 hours, the leukocytes start disintegrating. Yeah, so though the bedside filters do their job and they are efficient, but if it's a very old unit, then the leukocytes may have already liberated the cytokines, and which can bring about the non-hemolytic febrile transfusion reactions. But if you do a pre-storage leukoreduced components, where sometimes we have the lab side filters, we call it, or we also call it the inline filter bag, where the bags are pre-connected with filters, we are getting a pre-storage component. Or a simple method, if you want to prevent a non-hemolytic febrile transfusion reaction, you do the Buffy coat method of separation. Like, these are the various methods of leukoreduction. One is simple centrifugation, where you centrifuge and manually separate the white cell layer. Then it could be a Buffy coat removal, where we are using special blood bags called top and bottom blood bags. And I think we have it regularly being used in JANAKALYAN Raktapedi, where they perform Buffy coat removal for nearly all components which are being prepared in the blood bank. And even for special, wherever required, they use the filters, right? So that is one method where we are able to remove the entire Buffy coat layer with the help of an automated machines. You don't have to do any manual method. Then there are other methods like saline washing, which used to be done before, but it's an open system. So Buffy coat method removal and then filters are closed system and more efficient.
Right. So here we can say that we are now regarding leukoreduction technologies, we are moving from bedside to pre-storage integral bag reduction, because it has its own good advantages. So these are some of the pictures of leukofilters which are used. And sir has actually highlighted many benefits of leukoreduction or leukofiltration. Right, sir. Okay, so these slides we can skip. Yeah, this is the system, how the filters are attached.
How the filtration is happening. This is an example of a blood bag which has a filter already incorporated, and you can see how the filtration is being done in the blood bank.
Right, means WBC are being trapped over here and leukodepleted components are being collected over here. And using apheresis, obviously.
Apheresis machines themselves have a technology incorporated, where they are providing you leukoreduced platelets or red cells. Yeah, so that's also a part of leukoreduction.
Right, sir. So to summarize, leukoreduction actually helps patient to reduce many reactions and long-term effects. Coming to our last case, here I would like to highlight a very important problem which I initially told you, that blood transfusion may come up with long-term complications. So one case we faced, who was a 14-year-old male patient, was a known case of thalassemia major on regular blood transfusion every 15 to 20 days. He was receiving packed red cell transfusion since age of 7 months and was tested for HIV as a part of his annual health checkup. The test for HIV was positive for the first time during his treatment. So Dr. Atul Kulkarni, sir, can this infection be related to have been acquired through blood transfusion? Is there any possibility?
Yes, definitely. Most likely you can say. But to come to a definitive these things, we have to rule out other many things. But considering the time constraint, most likely what we can say, it's because of transfusion transmitted infection. During the testing protocol, we are not able to pick up, and hence the HIV has been passed from donor to the recipient.
It means this blood transfusion had some risk of transmission of HIV or a hepatitis B or hepatitis C. So always remember, in a clinical practice, when you take a decision to transfuse a blood component, it always comes up with some risk, and patient must be aware of that risk. Many a times during clinical practice, we see that we do not take informed consent of the patient to have that transfusion. So with help of this case, or with the help of this slide, we would like to highlight the point that informed consent of the patient is very much necessary, and one must follow all the protocols. One must take signature. If patient is not able to sign, his next to the kin or relative must give proper signature. Presence of a clinician is always necessary. Interpreter must also be there. And Dr. Kulkarni sir, if
Yeah,
you want
I
to
just
highlight.
want to add about this consent point. We have come across, not at my center, but another associated center. There was a litigation, and the case was similar to this. The patient got HIV, and at that time, the parties were hospital management, the treating clinician who ordered the blood, and obviously the blood center also. All three were the parties. For clinician, he was a party to it because he has not taken the consent. Hospital was a party because there was not a system to implement the proper guidelines about transfusion protocols and all these things in the hospital. And blood center was a party, not because they have not wrongly, the testing was something wrong or something like that. But after getting intimation from the clinical side, they have not tracked the donor and done the retesting. So the consumer code says that you have a malicious interest. So you should have called the donor, verified at your end. He may be positive, no issue. So why you have not done this? As the guideline says, if you have come across some case, you have to call the donor, verify it, and document it. But since you have not taken not followed appropriate guideline latter, that means you have some malified interest. So mind well, it is all are involved, not just a blood bank, not the ordering clinician, but hospital management also. Just wanted to highlight this tricky case.
It means, sir, it is a very good example of a situation where in clinical practice problems generally do not occur, but all those problems, they actually wait for many others to accumulate, and they hit everything at one time only. And this is exactly the case. Here I would like to highlight a very important point of window period. That is, though we test all the blood units at our blood center, which is mandatory according to FDA, but every test for HIV, hepatitis B and hepatitis C, or malaria, syphilis, every test has its own limitation, which is called as window period. And if the donor donates blood in that window period, we may end up in missing that case, and the disease can be transmitted. So, sir, what are the available options to prevent such kind of transfusion transmitted infections in the recipient? If you can highlight any scientific modalities which are available.
Yeah, obviously, I will club both the things
questions.
considering the time
constraint.
constraint. Definitely, important thing is strengthening for blood centers. Actually, for blood centers, strengthening your transfusion transmitted infection testing protocols, implementing EQUAS and all this thing, automation. So that is one thing. But still there is a limitation for the techniques that are used. As with COVID, we are familiar that rapid antigen test and antibody test and RT-PCR test. And we know that RT-PCR is a gold standard, because with these two we miss some thing. So similarly for us, again, these are the viruses. So RT-PCR based test will be the gold standard, and to implement them so that we will be able to cutting short the window period is the important thing. And hence, though it is not mandatory in India, but this is the high time that, considering the risk involved, management of HIV, the patient after getting a transfusion transmitted infections like HIV, hepatitis B, the risk of litigations and all these things, it is always better to go ahead with RT-PCR based test, nucleic acid test, and with some extra cost, not exhaustive, but with some extra cost, this can be prevented.
Right, sir.
So,
the transmission of HIV, but as well as hepatitis B and hepatitis C is also having very high risk. You can see the window period of hepatitis B and hepatitis C is quite high for routine ELISA test. But by using nucleic acid testing, we can reduce that window period very significantly and make our blood component much safer. So with this, I would like to say thank to all the management, IMA, and everyone over here for your patient listening. So take home message will be do not transfuse, or transfuse only if it is very much necessary.
Yeah.
Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Patil, and thank you, Dr. Kulkarni and Deshpande, for an excellent discussion. May I request Dr. Nimkar Madam to come on to the stage? To felicitate, she is the past president of IMA Pune. Yeah, first it is the moderator. Yeah, officially. I just give a vote of thanks to mainly Dr. Kulkarni and the JANAKALYAN team for an excellent excellent CME today, as well as for the blood donation drive. For the whole team, we are very grateful to you, sir. Also, we are grateful to Jain social group for blood donation. All the faculties, I would like to thank them, and all the delegates who are online as well as who are physically present over here. I would like to thank all the MC members of IMA and the past presidents, the audiovisual team and DigiShield for the platform, Mr. Mirazkar for photography and video. I would also like to thank caterers for today, Shreya. And of course, last but not the least, our own staff, Mr. Aniket, Daude Kaka, and Mr. Santosh and everybody from IMA, without whom we cannot do such seminars. Thank you very much. And I declare that the CME is over. Over to you, Mr. Deepen. Thank you.